Good morning and welcome everyone to our Disease Intervention Specialist Retention, Recruitment, and Training webinar. For more than 40 years, disease intervention specialists, contact tracers have helped in the response to infectious disease outbreaks. They are integral components of STDs, tuberculosis, and HIV prevention and control programs around the nation. They have also been called upon throughout the years to respond to emerging threats like Ebola, Zika, as well as outbreaks and clusters of hepatitis A, hepatitis C, and HIV. Their unique skill sets and role in intervening in the spread of disease came into the spotlight in 2020 as a critical component of our nation's response to the COVID-19 pandemic. Some will say that they represent the boots on the ground of public health. This webinar will focus on three important issues surrounding disease intervention specialists: disease function, retention, recruitment, and training. It will include presentations on patterns, trends, challenges, and solutions. The goal is to continue the discourse on improvement and enhancement of disease intervention functions as the DIS workforce expands. Here are some important meeting rules. In the interest of time, we have minimized the chair function. To each speaker, please introduce the next speaker by name only. Speaker's background information and institution affiliation are in the bio packages that were sent to you. And please put all comments and questions and suggestions about knowledge gaps in the Q&A box. We will address them during the Q&A session at the end of the program. And finally, we do not have a chat box to minimize distractions. I would like to thank, to give a profound thanks to the speakers and Q&A moderators today. Next slide, please. The recording of the meeting will be available on NPIN's website. Next slide, please. Finally, I would like to thank the organizing committee led by Dr. Seth Guiaral for the many hours of thinking through these issues, preparation, and development of an agenda that promises a very interesting meeting. Next slide, please. Now, without further ado, I would like to introduce our first speaker, Julie Kraut-Beecher. Is going to talk to us about DIS retention.
Good morning. I'd like to begin by thanking Sev Guiaral for inviting me to be a part of this webinar today on DIS retention, recruitment, and training. Some of my most impressionable experiences as a postdoctoral fellow at the CDC in the Division of STD Prevention involved time in the field with the DIS in both Birmingham, Alabama, and the South Side of Chicago. I have since spent about 20 years in the HIV Prevention Research Division in the Perelman School of Medicine at the University of Pennsylvania, where I've been involved with the development of recruitment and retention plans for numerous HIV education and vaccine clinical trials. As a labor economist, it is my pleasure to be here today to talk about retention of workers in today's labor market, as well as discuss patterns and trends in both domestically and globally. Next. A health department, potentially hiring DIS, like any organization, may have goals for its human resources to lessen employee turnover and increase retention. Retention rate describes how many employees stay within an organization over a given period of time. So essentially, you're measuring the organization's stayers. Whereas employee turnover is defined as the number of employees who leave an organization for any reason over a specified period of time. And so this is a measure of the organization or leavers. So employee turnover is very important for organizations because it's extremely expensive to replace trained staff. We'll hear more about these costs from Tom Gift in the next presentation. So essentially, a high rate of retention, a high number of stayers, is a positive thing for an organization, whereas a high rate of turnover, the number of leavers, is a negative thing for an organization. Currently, employee retention rates in the United States average about 90% and vary by industry. When we look at relatively recent data, we see that employee turnover rates have increased substantially over time. While it was almost 43% 5 years ago, or now I guess 6 years ago, it was almost 43% in 2016, it's increased to well over 50% by 2020. But not all turnover is the same. Next slide, please. Historically, we used to focus on what is referred to as involuntary turnover, when the employer severs the employment relationship through firing for bad performance or due to layoffs. However, in our current hyper-competitive talent labor market, the focus is now on voluntary turnover, when an employee decides to leave their job through quitting. In fact, the number of Americans quitting their jobs has reached a record high. More than 4.5 million people voluntarily left their jobs as of November 2021. This is 3% of US workers who quit their jobs in the month of November. This is the highest on record in the past 20 years that the Department of Labor has been tracking this information. This increase in quitting has been dubbed the Great Resignation. Next slide, please. So who are the quitters, right? An article in the New York Times last week reports that the number of, that much of the job turnover has been concentrated in low-wage workers and in hospitality industry, for example, where intense competition for employees has given workers the leverage to seek better pay. Next slide, please. Chances are, if you've walked around or driven through retail centers, you can't help but notice these signs on the windows, right? Help wanted everywhere for hiring, now hiring. Just these signs are quite prevalent at the moment. Data from the Federal Reserve Bank of Atlanta shows that job switchers are getting significantly faster pay increases than people who stay in their jobs. So, for example, in these hospitality and leisure industries, hourly earnings were up about 12% in November, which is much faster than the rate of inflation, which is currently 7%, which is a record high over the last 40 years. Workers in other low-wage service sectors are also seeing great gains. Our average hourly earnings have only risen about 5% in November. So for those who cannot change jobs so easily or in sectors whose demand isn't as strong, pay gains have been more modest, right? And some have been lagging price increases. So workers tend to have leverage right now, but they have to use that leverage, right? Take advantage of it and be willing to use it in order to gain and not be left behind in this market. Next slide, please. So we have all these quitters. So when are they quitting, right? So, voluntary turnover depends on decisions made by an employee. So it's much more difficult to predict. So I thought it was interesting to see, like, when do people quit? So a private research recruiting firm in 2018 published a study where they looked at 1,500 workers in the United States and reported that about a third of them quit their jobs within the first 90 days that they're employed. And of these, a half of them stated that they quit because the position didn't align with their expectations that were built in the interviewing process period. So if we look at this graph, we can see that almost 16.5% of these quitters quit their job within the first week of employment, and a little over 17% of the quitters quit within the first month of employment. About 15% of employees who quit do it after 6 months. Next slide, please. So turnover, or job separations in general, includes quits, layoffs, and discharges, and other separations. And other separations, we're referring to those due to retirement, death, disability, and even transfers to other locations within the same organization. Quits or voluntary turnover accounted for about 70% of all total job separations in April 2021. This is staggering when compared to a year before, where it was only about 17.25%. This record high percentage is interesting to look at and think about. And you can see here how it's changed, pre-pandemic versus during the pandemic, and then how it's, bounced back and even grew. So we can think about, as of November, we see that there are 6.7 million hires were made in November of 2021. And we see 4.5 million people quit their jobs in November 2021. So this suggests that most quitters moved on from one job to the next instead of leaving the labor force. So that's a good thing, potentially. All right, next slide, please. So before we go on to talk about patterns in job retention, let's talk about how these measures are calculated. All right, so for example, let's say I'll use my local health department, the Montgomery County, Pennsylvania Department of Public Health. Let's say they had 10 DIS on their staff as of January 1st in 2021, and 9 DIS at the end of the year on December 31st. And so they just lost 1 DIS. So we could see here that the calculation for the retention rate would imply that they have a 90% retention rate. So the retention rate is interesting, but it's misleading, right? Because if we use this formula, the number of stayers divided by the number of DIS at the beginning of the period times 100, what we might miss is what if the Department of Public Health hired 2 additional DIS after the first of the year, and at least one of them left, in addition to the one here that we're implying left. So we don't catch that in the retention rate, right? So simultaneously calculating the turnover rate gives us a more complete view of worker movement than measuring either metric alone. So let's talk about the turnover rate. So if the Montgomery County Department of Public Health had, let's say, 20 DIS employed in the year 2019, 6 of them left by the end of the year. A simple turnover rate is just 6 divided by the 20 times 100, which gives us a turnover rate of 30%. But again, not all turnover is voluntary. So voluntary turnover, again, is made, is when the choice is made by the employee themselves, right? And so reasons might include, a variety of factors, job dissatisfaction, little feedback, not much advancement opportunities, compensation, etc. So it's important to identify these problem areas or, to make changes, right? And try to keep your employees. So let's look at how to calculate the voluntary turnover rate. So let's say we had 6 DIS leave in 1 year, but only 2 turns out due to reasons they were dissatisfied, whatever reasons those were, whether compensation or career opportunities. Hopefully there's some good exit interview strategies that can help assist the department figure out why the employees left voluntarily. But let's say the 2 left. We can say then that there were 20 over the year. So we have 2 divided by 20 times 100, which tells us the voluntary turnover rate is 10%. Now, the other 4 might have left for other reasons. Maybe some retired, some moved to another part of the country, or some might be terminated for poor performance. Okay, next slide, please. Tenure is the length of time that an employee has worked for an organization. So we need to calculate the average tenure in order to find out how long employees stay at an organization. This information can be useful when planning strategies to retain employees. So let's see, here's what you can do. You look at the number of DIS that we have, that the health department has, and how long they stayed, right? And just figure out the total number of, in this case, years. It could be any unit of measurement. It could be months, it could be a bunch of months, whatever your time period of interest is. So in this case, it's years, and then we can take the total number of years that the employees stayed divided by the number of DIS, and we can figure out the average tenure of the DIS stayers. Note that you can also do these calculations, figure out the average tenure of the leavers, right, as a measure of longevity, the total months worked before quitting. You can also analyze special characteristics of the turnover rates. Let's say you want to look at voluntary turnover by supervisor or longevity, or even shift work, like night shift, for example. Okay, next slide, please. So now we'll look at patterns and trends in retention. So how long do employees stay at their jobs? Well, if we look at this biennial data from the Bureau of Labor Statistics on employee tenure, we see that Americans have a general trend towards shorter tenures. The median number of years that wage and salary workers had been with their current employer was 4.1 years in January 2020, which was just a slight decrease from 4.2 years in January 2018. The median tenure of workers can vary, right? It can be affected by a number of factors, including changes on the labor demand side of the market, such as changes in the number of hires and separations, as well as on the labor supply side, such as demographic characteristics such as gender, race, the age profile of workers, and the level of education. Next slide, please. So does tenure vary by gender? So in 2020, both men and women spent less time in the same job positions than they did a decade ago. And we can see here that in January 2020, the median employee tenure for men was 4.3 years, which was basically unchanged from 2018. For women, the median tenure was 3.9 years in 2020, which was a little different from the median in 2018, which was 4 years. For employees 25 years and older, what we see is that women were more likely to switch jobs and had a median tenure of 4.8 years at the same job compared to men who stayed at a job a little over 5 years. Overall, women are staying at their same jobs around 3.6 months less than they were 10 years ago, and men are staying 2.4 months less. Next slide, please. So does tenure vary by education? Well, it seems like it's more varied, and tenure differs by the level of education, but it's more varied if we look at it by gender. So what we see here is that the more educated male workers are, the longer their tenure at a single job. But the relationship's not as strong for female workers. So what we see on the lower end of, less education levels, that tenure was the lowest on average. And then for the higher levels of education, tenure was longer, as we might expect, right? But even then, we can see this differential across genders. Even at the higher end, you can see that women worked almost about a year less on average than men. Next slide, please. Does tenure vary by age? Well, what do we see here? We see that the younger workers tend to work the shortest amount of time with their current employer, right? They have the shortest tenures. And this was probably not surprising, right? High school and college age young adults job hop the most. And then again, that's what you would expect, right? Because a lot of them work during vacations or try to find jobs that fit their schedule, try out internships, etc. Young professionals, even under the age of 34, are relatively new to the workforce, tend to stay in the job a little bit longer. And you can see that with the purple line here, where they take their time to decide whether a position is a good fit for their skills and professional ambitions. Next slide, please. Here we look at the difference in median tenure from 2010 to 2020 by age group. And we see that among the younger age cohorts, 18 to 24-year-olds, their average tenure in 2020 was about 2 months less than in 2010. And the tenure, which are an average between 8 months and 1.3 years. And tenure among employees between the ages of 25 and 34 was on average 4 months less in 2020 than it was in 2010. And that averaged about 2.8 years in one job before moving on to something else. Employees about 35 years and older also spent less time in their jobs in 2020 versus 10 years ago. But their average tenure is substantially higher compared to younger Americans. Employees between 35 and 44 years old spent 4.9 years on average at the same job, followed by 7.5 years among 45 to 54-year-olds and 9.9 years among those between the ages of 55 and 64. So there's a bigger jump here in job tenure between the age groups of 35 to 44, and 45 to 54. Next slide, please. Does tenure differ by race and ethnicity? So looking among the major race and ethnicity groups in 2020, we can see that the percentage of employees that stayed with the same employer for 10 or more years was about 29% of whites, compared with 23% of Blacks, 26% of Asians, and 22% of Hispanics. Next slide, please. Do Americans stay at their jobs at a similar rate as workers in other countries? If you look at the job tenure among selected OECD countries in 2019, we see that Americans spent less time on average with the same employer than employees in all these other countries in Europe and East Asia. Next slide, please. So in summary, in 2020, Americans were spending less time in the same jobs compared to the average tenure in 2010. While certain generations have a reputation of being chronic job hoppers, data shows that tenure is more a matter of age group than generational cohort. Younger employees across generations job hop the most, right? And while younger generations spent less time with the same organizations compared to older employees, Americans of all ages are moving on to new opportunities at a faster rate. Gender and education may also have implications for average employee tenure. American workers are moving to new opportunities much faster than ever before, which suggests that their current employers may be failing them in some way. So in order to increase retention, organizations may need to change and adapt, right? By offering some more growth opportunities potentially, or increasing pay and benefit options, or just offering more flexibility in job schedule and location, maybe boost some incentives, etc. So while it's difficult to point to a single factor behind increased turnover, one thing is for certain, that decreasing retention rates are costing the economy tremendously and could have long-lasting impacts. Next slide, please. Thank you very much. And next, we'll hear from Tom Gift about the cost effectiveness of retention.
Good morning. I am Tom Gift. I'm the Acting Chief of the Clinical Economics and Health Services Research Branch. Next slide, please. So today's presentation is going to be really broad and high level. You just heard a lot of data on retention rates, and you saw how widely they varied by different factors. The data I have here on this slide are not nearly as detailed as what you just saw, but retention rates vary greatly by industry. Legal and management, as of January 2020, it was about 6 years versus 2 years for food preparation and service. And then worker characteristics matter. As you saw graphically portrayed about 3 slides ago, younger workers have much less time on the job than older workers. Next slide, please. So before we talk about whether retention is cost effective or not, we have to address whether retention is a good thing. One of the ways that people assess the cost of employee turnover is looking at the cost to replace those employees. And the estimates range widely. You see that here at the top, I have a couple of sources that have a fairly wide range from $2,300 to $18,800. Oftentimes, these cost estimates just look at the cost of onboarding, advertising for a new hire, and then maybe some preliminary training. Other sources suggest that the cost can be up to 33 to 50% of 1 year's base salary for higher skilled positions. And again, this varies widely by position and industry. As you would expect, positions that don't require as much training are easier to hire new people into. And the costs that are depicted here often exclude the productivity implications. And the productivity implications are not just for the new staff who don't know the job very well, so they're not productive when they're starting, but also the people who have to go about the task of hiring and screening applicants. They're taken away from their other duties, so there's a cost there as well. Impacts of low retention include productivity. As I just mentioned, it's not just the new hires, but it's the people who have to do the hiring and onboarding. It can cause low morale among those who stay behind in the job after some people leave. And in sort of a downward spiral, low retention rates can cause further retention problems as workloads are shifted and the people who are still on the job find that their working conditions deteriorate as others leave. Next slide, please. So for cost effectiveness analysis, this is something that medicine didn't really look at prior to the 1970s. I've got a screenshot here of an article that's about 45 years old. The underlying premise of a cost effectiveness analysis from the paper is that for any given level of resources available, society wants to maximize the total aggregate health benefits conferred. And then alternatively, for a given health benefit goal, the objective is to minimize the cost of achieving it. Next slide, please. And those two bolded subsections identify the two sides of cost effectiveness analysis. You've got a given level of resources and you want to do as much good as possible with them, or you've got a given goal and you want to achieve that goal as cheaply as possible. Next slide, please. Some considerations that are relevant for cost effectiveness analysis. One is that something doesn't have to be cost saving in order to be cost effective. When something is cost saving, that means that the money you spend to achieve an objective is overwhelmed by the savings you realize as a result of achieving that objective. In other words, the money you spend on recruitment and retention is overwhelmed by, say, productivity gains in the new staff that you attract. But sometimes spending more to get more can be optimal. That doesn't necessarily mean that it's going to be achievable given budget realities, but it's not necessarily true that the intervention that has the lowest cost is the best one. And when you measure costs, you need to have more than replacement costs. Productivity differences matter too. And can you go to back one slide? Looks like it advanced. Thank you. And then the perspective and time horizon are important as well. Time horizon is just how far out you count the costs and impacts of the intervention that you're studying. You might be interested in a one-year time horizon, or you may be interested in something shorter or longer, depending upon what the needs are. You need to have an outcome to assess cost effectiveness because the cost is expressed per unit of outcome. And sometimes the way people get away from this and having to identify outcomes and quantify them is that they reduce everything to dollars and they do a cost-benefit analysis, but there are few of these that are done in the field of healthcare right now. Next slide, please. Here are some of the outcomes that might be reasonable for assessing the cost effectiveness of retention. The percentage of worker slots occupied, if you want to just maximize your average workforce, average worker tenure, the turnover rate, if you want to minimize that, worker output, which could be expressed as cases investigated, patients treated, partners notified, maybe a composite that has all the above. Or if you wanted to look at less quantifiable things, you may be concerned about outbreak readiness. DIS across the country got pulled into COVID contact tracing, and then prior to that, H1N1, SARS, and other outbreaks back over the last 20 or 30 years. That's a prime advantage of having a DIS workforce. Next slide, please. So there hasn't been much published on DIS retention, but there has been a bit of work on nurse retention because nurse retention is a chronic issue in the healthcare industry. Nurses work very hard. Their salaries often do not compensate for the difficulties they have on the job. So some of the interventions that have been studied in nurses, just to give you an idea of the options, structured orientation programs have been found to be helpful. Give new employees a better idea of their role in the organization and how their job fulfills the mission. Internship residency programs, sort of a try before you buy for new employees. Orientation and transition to practice programs. Preceptorship and mentorship. Preceptorship being more of a formal training one-on-one role, and then mentorship, which could extend to other areas of the work experience. And then one study looked at a focused intervention on preceptors, trying to train them to be better preceptors, and that was found to have a favorable cost-benefit ratio and improve preceptor retention. And then empowerment, shared governance, autonomy, and then adequate staffing, again, to minimize the extent to which workers are asked to assume extra shifts an extra workload and improve retention. Next slide, please. So I'm going to go through an example just to show you what some of the issues are potentially in looking at the cost effectiveness of retention. I see that my numbers got a little bit messed up, but you can sort of read through all that. We've got new and experienced DIS, and these numbers are completely fictitious. I made them up, but they illustrate concepts, and hopefully the numbers are close enough to reality that that doesn't distract from this. Let's assume for new DIS that you spend about $5,000 for onboarding and recruitment. The salary for a new DIS is $50,000 the first year, and they can work about 100 cases. 25% of them quit, though, because as you saw in the previous presentation, a lot of people realize pretty quickly they don't like the new job that they're in. Experienced DIS, they get paid more, they can work more cases, and they have a quit rate as well, but it's lower. For the calculations I'm going to show you, the assumptions are really simple. All the DIS start on January 1st, and if they're going to quit, they quit on December 31st, so they work the full year. And then new DIS become experienced DIS after 1 year, and so overnight, New Year's Eve to New Year's Day, their productivity doubles and their pay goes up. Next slide, please. So at baseline, when you use those assumptions, if you look over 10 years, let's assume that we have a target of having 100 staff in the DIS workforce. The average size of the DIS workforce at year's end over that 10 years, using the numbers on the previous slide, it's going to be 88. Total number of cases worked over that 10 years, 189,619, about 19,000 a year. Total cost, and this is for wages only, that's all I'm counting in this, and the onboarding costs, about 64 million, and the average cost per case is 337.32. Next slide, please. So let's look at some retention options. So I've shown you the baseline. What if you increase the starting pay for new DIS from 50 to 55,000? That might help attract new people, and maybe it would reduce the new DIS quit rate to 10%. Or maybe start a mentoring program. I mentioned that has been shown to be effective in the nursing field. Maybe that would reduce the quit rate for new DIS to 10% and possibly reduce the quit rate for experienced DIS a little bit as well, because having a role where they're showing people what their job is and explaining the importance and how to do it well, that could reduce the quit rate of experienced DIS. It would potentially increase the productivity of new DIS and maybe lower the average productivity of experienced DIS a little bit because they have some mentoring duties. And we'll use workforce size, the average number of staff, and then cases worked as our outcomes. Next slide, please. The starting pay increase might be one that would not be favored because that involves writing checks. It's a hard cost. The program managers know that they're going to be paying additional costs, so they might be inclined to support the mentoring program, but we'll see how this works out. Next slide. Here are the three options sketched out. And again, I think the font size ended up being too large, so you've got a little bit of a challenge in reading this, but the big numbers are what is important. You see that under the assumptions I just showed you, the baseline is what I expressed before. Increasing the starting pay increases the total number of cases worked because more new DIS stay to become experienced DIS. And you see the average staff, the column over on the right, it goes up. And then mentoring, you have more staff as well, and then relatively higher costs than the baseline as well. To calculate the cost effectiveness, we order these from least effective to most effective and then calculate the cost of switching between them. Next slide, please. And so here they are when they've been reordered. We're going to look at cases worked as our outcome initially. So mentoring is the least effective in total cases worked. Just the baseline, what you've got now before you consider these alternative interventions, that works more cases, and it's cost saving. I have that over on the left. What does cost saving mean? Well, when you look at the total cost, that's the middle column there, total cost millions of dollars. Mentoring is more expensive, and it's got $64.27 million over the 10 years versus $63.96. So you're spending more with mentoring. You're getting fewer cases worked. So if cases worked is what you care about, then why would you do mentoring? You just stick with what you've got now. And then starting pay, increasing the starting pay, the total cases worked is the highest of all. It is more expensive than the baseline. You see, you spend over the 10-year period $425.94 per each additional case worked. Next slide, please. So now when we look at the average staff as an outcome, we got to reorder the table because baseline had the smallest average staff over the 10 years, 88. And then mentoring was the most effective at maintaining the workforce and having people available to do the job. That had 92. And then increasing starting pay was somewhere in between. So we calculate the cost effectiveness ratio, again, moving between the options, except now our outcome is an average additional staff person. And you see that if you increase starting pay, you're going to be spending about $300,000 per additional staff person in the workforce over that 10-year period, about $29,000 per job. And then mentoring is cost saving compared to starting pay, because look at the budgets. Starting pay has a total cost of $64.55 million, and mentoring is $64.27 million. So mentoring has a larger workforce, if that's what you care about, and it's cheaper than increasing starting pay. So why would you increase starting pay? Next slide, please. And so basically, the numbers in the table were the same except for the ratios. I just sorted them based upon the outcome that was interesting. Baseline is favored over mentoring if the cases worked as the outcome, but then mentoring may be favored over the baseline strategy if the average staff is the outcome. I didn't mention it before, but one of the sub-bullets on the previous slide showed that mentoring compared to the baseline, once you get rid of the increasing starting pay option, shows that you're spending $76,259 per average staff person over 10 years, or about $7,600 per year per additional job. Next slide, please. Now let's consider a different scenario. What if it costs, or it takes a while to hire people? So someone who vacates a job on December 31st, it takes a year to fill it. So the vacancies that happened on December 31st, 2020 aren't filled until January 1st, 2022. That changes things a little bit. And let's assume that in this job market, onboarding and recruitment costs double for new hires. So you go from 5,000 to 10,000. Next slide, please. So when we use cases worked as the outcome, this is what it looks like. The baseline, increasing starting pay, and mentoring in terms of increasing cases worked. Mentoring now is the best. Earlier, it was not. It was, it was fairly poor in terms of total cases worked, but now it's the best one. And it's also the most expensive. You see the total cost is $58.5 million for baseline, $59.63 for starting pay, and for mentoring at $60.26. So you can look at the cost here, incremental cost per additional case worked. Starting pay versus baseline, you're spending $373.12 per additional case worked. And for mentoring, you're spending $1486.40 per additional case worked. So that's relatively expensive. And increasing starting pay is more effective than baseline with a smaller incremental cost effectiveness analysis than mentoring versus the alternatives. Next slide, please. So now let's look at, I think we went forward too. Could you, yes, right there. Average staff as outcome. So if we care about the total number of average staff, you see that mentoring is the best because it has the largest workforce. You'll notice that the average staff, the workforce size has gone down. Earlier, we were looking at numbers from 88 to 92. Now it's 80 to 86. That's because of the delay in hiring. And then the incremental cost effectiveness ratio over at the far right of the table shows you the cost per additional staff person. Increasing the starting pay is a relatively inefficient option. And so if you drop that out of the table, the incremental cost effectiveness analysis for the mentoring program versus the baseline, what you're doing now would be $281,000 per additional staff person, or about $28,000 per year. Okay, next slide, please. What these two examples show is that the optimum might differ depending upon the outcome chosen. What you care about will determine the optimal strategy. And then the workforce environment, which can change, will also impact what the optimum is. The reason I picked that example as it was to show differing work conditions when situations were otherwise pretty similar, as might prevail in a health department. The previous presentation showed you how much things have changed in 2021 versus earlier years. So something that might work for employee retention in 2018 might be obsolete circa 2022. And it requires adjustment, assessment, evaluation, and nimbleness to change as job market conditions change. So the data needs to do evaluations of this nature. You've got to have data on costs and outcomes. And it's best to have data on outcomes under varying conditions if possible. If you're a health department that hasn't ever done any of these, you might have no idea what the outcomes are. And one way to get data to inform the choice is to do demo projects. And failing that, if there are success stories in other health departments, if there are other health departments that have implemented programs for DIS retention that have worked, and you can get some of their data in terms of what it did for their outcomes, whatever outcome matters to you, cases worked, whatever, then that can help provide estimates for what the implications might be for your program. Next slide, please. So in summary, retention is a good objective, but finding cost-effective strategies to achieve retention goals can be challenging. Retention strategies that work have been researched in other fields. Some have no relationship to DIS, and then others perhaps are reasonably close and can provide some inspiration. And assessing the cost-effectiveness of options requires data on costs and outcomes for all alternatives in order to be able to do the best estimate possible. And I think that's all I have. Next slide, please. Yes, so thank you very much, and I will pass it next to Dawn Broussard.
Thank you, Tom. Good morning, everyone. As you see here on the slide, Romney Nyman was scheduled to present to you all this morning on DIS perspectives on retention. I'm sorry, Romney is not able to join us today, and she extends her apologies, so I'm filling in for her on this presentation. So just a quick overview, we're going to be covering perspectives on DIS retention, including turnover, challenges that are faced in retention, and then quite a bit of time on facilitators to retaining good DIS staff. Next slide, please. First, we're going to start with a little bit of data. These data are from 2017 from the DIS enumeration survey that the Public Health Accreditation Board conducted. Probably not at all a surprise to this audience, but nearly half of the health department, well, let me back up a minute. Every health department reported turnover in DIS staff, and of the health departments that responded, nearly half of them indicated that their average tenure for DIS was between 1 and 3 years. Next slide, please. So there are a number of challenges in DIS retention, and probably all of you are well versed in these aspects that you're seeing in your own health departments. Certainly DIS positions are an entry point into public health programs. For many staff, this is a position to get your foot in the door into public health. And the unique and rich opportunities and experiences that they gain can be a springboard for many other opportunities, including MPH programs, medical school, advancement opportunities in governmental or non-governmental public health or community health. Those who do wish to grow and develop within a longer-term career within a DIS focus or a disease intervention focus, excuse me, may simply experience a limited promotional pathway in which to do so. The lack of formalized DIS training pathways and the absence of an off-the-shelf model for hiring for DIS skills, as you might see for epidemiologists, public health nurses, et cetera, can lead to a mismatch between employee expectations and job duties. While the goal of DIS work is an incredibly and important and meaningful one, intervening in disease transmission, what it can entail is frequent rejection and daily delivery of difficult news that people do not necessarily want to hear in order to protect the health of clients, their partners, and the communities that DIS are serving. Excuse me. On a daily basis, DIS need to employ empathy and conflict resolution, and it's not easy to consistently remain comfortable in that space. And certainly accompanied with the stress of high caseloads, ongoing exposure to trauma, and compassion fatigue, it's no wonder that DIS also often struggle with burnout. Next slide, please. Oh, now we're going to spend a little bit of time walking through strategies that can contribute to retaining good DIS. As the cliche goes, you only have one chance to make a good first impression. And this first speaks to the solid foundation that's needed to get DIS out and on board and starting on the right foot. This can be challenging because building a solid foundation takes time, and there is the tension between taking the time to train staff, getting them up and running, and the desire to have them proficient and working right away, as DIS workforces have been so thin recently. So again, within building this foundation, there are two key steps, and they can be very time consuming. First is hiring the right people, which can be easier said than done. Ideally, new hires will come in the door with a clear understanding of this unique role, including both the technical and the soft skills that are required. And then shortly thereafter, they'll begin to move through a clear and detailed plan for obtaining the proper training and support to succeed in their positions. Formal training and translating that training into real-life practice is paramount, but has been challenging in recent years as DI staff have been stretched so thin. We'll talk in greater detail about training later in today's session. Next slide, please. As you all probably have experienced, new DIS can easily become overwhelmed by the complexity of the training and the responsibilities before them. They will need to be provided with clear expectations, and it can only help to periodically repeat and reinforce those expectations given the amount of training and complexities that DIS face, and then providing them with systematic support. Valuable support includes assisting them with prioritizing and planning their work, including when to let go and close out assignments when there's nothing more to do, which can be really hard for new DIS, and providing them with updated info on where and how to refer clients to health and social support services. Recognizing there are different learning styles, they'll also benefit from a variety of job aids and tools. Next slide, please. Creating opportunities for ongoing professional development for DIS is really important. As you all well know, these can take on a number of shapes. There are a number of ways of promoting professional growth, and I'm sure you all have others to add. They can include opportunities to attend training or attend public health conferences and forums to learn of updates and innovations in science and practice. Peer-to-peer sharing of best practices, including in forums such as collaboratives, communities of practice, case conferences, or chalk talks. Assigning DIS progressively complex case management assignments or responsibilities, such as HIV care coordination, fetal syphilis, congenital syphilis, etc. Special projects assignments, such as correctional liaison, provider detailing, community outreach, and education. Outbreak response deployment, certainly DIS have had plenty of opportunities to do that in the past 2 years. And then mentorship assignments. And a piece of professional development too is, given these opportunities, can break this routine of the heavy caseloads and the burnout that DIS can get into when they're constantly being assigned large volumes of cases. Another facilitator is formal recognition. While creating more formal pathways for professional development may be challenging and can take more time, it's a valuable endeavor to retain qualified staff. But these pathways for formal recognition are critically important. Certainly promotional opportunities have value for DIS in staying engaged and staying motivated in the work that they're doing. And then as you all are becoming aware of the efforts for DIS certification, this will create a national standard with a baseline for experience and competency requirements. The goals of DIS certification include improving public health services provided to communities by DIS through a high quality, standardized approach to the professional development of the workforce. Certification can standardize and validate the knowledge, skills, and abilities of DIS, drive the standardization of the series, improve training, and increase recognition and awareness of the skills and abilities of DIS nationally. Next slide, please. We can't speak enough about the importance of self-care in facilitating support for DIS and helping to retain good staff. Certainly, it's been a focal point it's always been a concern, but particularly over the past 2 years, it's really come to the forefront of how important this is. We've already acknowledged that DIS work can entail rejection, conflict resolution, exposure to trauma, and this need to deliver difficult news to people who have a number of challenges in their lives and don't necessarily want to hear the information or can't process the information that DIS are telling them because of the heaviness of it. This work can take its toll, and it's important to acknowledge and build in supports for self-care. DIS need opportunities to recharge their batteries. We look forward to hearing from all of you about successes you may have had in this critically important area. Next slide, please. So I know that was a quick thumbnail overview of recommendations that can potentially aid in retaining good DIS. To recap some of the facilitators we noted here, we talked about the importance of a strong foundation, having the front end of a DIS onboarding be very well thought out and detailed, ensuring that DIS are aware of expectations and reminded of expectations, and that they have supports to succeed in those expectations. Providing them with opportunities for professional growth on a regular basis to ensure that they're current and do have some breaks from the routine. Formal recognition is a piece that's close to our hearts. We really want to make sure that there are supports in place to value the important work of this incredible workforce. And then certainly self-care, doing what we can to provide support to DIS and doing this difficult work that's in front of them. And this concludes my presentation. Again, Romney's presentation, my apologies. And we look forward to more robust discussion on this topic throughout the day. Thank you so much for your attention and interest in supporting this workforce. And now I will turn it over to Dr. Aral for the next piece. Thank you.
Hi, actually, this is Jennifer. I'll take that actually as the moderator for this session. Thank you for all of the 3 wonderful talks, and we appreciate Dawn for stepping in at the last minute to share Romney's presentation. The first question I have is actually for Julie. Are millennials and Gen Zers really actually chronic job hoppers?
Yeah. So that's a great question. Thank you. So yes, the millennials and the Gen Zs have a reputation of getting bored easily at their job, and so they tend to move along, and want higher pay, and they move along quickly. But as we saw in one of the slides with the age trends, it's really just like the younger age, no matter what generation they're a part of, the younger age employees tend to switch jobs more often. So millennials are now probably 24 to 44. And so they're in the range where they're staying a little bit longer now. Right? So it's more about age than a generational cohort effect.
Thank you. I think that's going to be helpful to people to keep in mind. And next question is for Tom Gift. Is it ever cost effective not to retain workers?
Well, so with cost effectiveness analysis, you've got alternatives. And the question might be, if you have a retention goal, can you realize it at a cost that is feasible? And in our current job market, this has been particularly something that's been seen in nursing, where the working conditions have been very difficult over the last couple of years. There have been a lot of people leaving, which has shifted the burden onto those who remain behind. And with the instability in the workforce at large, starting salaries for entry-level jobs have gone up to where many nurses are making a calculation that for themselves taking a slightly lower salary is attractive compared to the better working conditions that they can get elsewhere. So yes, sometimes keeping people on the job might require something that's not feasible. And so then the only alternative is to develop a really good training program to get people up to speed quickly.
Thank you, Tom.
Can I add something there?
Yes, absolutely.
Not being cost effective. Just this week, I just heard about a software company in Arizona that's offering their employees $5,000 to quit. And so what they found was if they can quit within the next the first 2 weeks of this offer, that they will save money because, they save all the training costs, et cetera. If the employees know that they're going to leave, they just want them to leave right away. So I thought that was interesting that they're paying people to leave.
Yeah, and I'm assuming, Tom, that the time horizon that you're looking at the impact makes a huge difference as to whether the allowing people to go makes a big impact.
Yes, I mean, that's definitely interesting. I hadn't heard that.
Well, thank you for those answers. Dawn, I don't know if you're willing to field some questions. I know that wasn't your presentation, but you have a deep experience and background in the field.
I'm happy to do what I can. Absolutely.
Okay.
I'm game.
Can you speak a little bit about why ongoing professional development for DIS is important?
Absolutely. And again, from my experiences, perspectives, there's so many different reasons. One is just to stay current. We hear DIS talk about frequently is, oh my God, the lab tests change so much. I need to understand this to be able to talk to clients and providers. And so there's just staying current, and things change quite a bit. There is the need to break the routine. I think everyone's hopeful with an expanded DI workforce that the DIS that we do have won't be stretched so very, very thin. I mean, incredibly thin. But breaking that routine of the heavy workloads, the difficult work that they do, having that moment to step away and say, okay, I'm going to invest in my professional development that will help me do this work better. Having perspectives on doing this work from a health equity lens, et cetera. It's very easy in this work to feel like you're stuck and you're on a conveyor belt of, tens and dozens and hundreds of cases that are coming in and never quite stop. So, I think every employee wants to grow and develop in a field that they care about. And we hope people come into DI work and really care about it and want to stick with it for a long, long time. But I think it's also just acknowledging that we value this workforce. We want you to feel like you're learning and being challenged and able to take on increasing responsibilities in public health or wherever you're doing DI work. And I think the underpinning of all of these DI conversations is the value of this workforce and investing in them and helping them feel supported in what they're doing.
Thank you, Dawn. Good advice, I think, for sure. Julie, I have a couple actually related questions. The first is, why does tenure increase for men by education, but doesn't appear to do so for women?
Hi, thank you. I think that's a great question as well. I think that certainly there's a gender wage gap that's involved, but it's not considered in these graphs, where we present these retention trends. So that's something to consider. I think I saw a question in the chat box about that as well.
Yes. Yeah, that was the second question I was going to ask you.
Thank you.
Tom, what costs other than recruitment and productivity are relevant for the cost effectiveness of retention strategies?
Well, if you're going to use a broad enough perspective to capture it, when the DIS are out working their cases, there are going to be costs that are going to cascade from that. For example, if you are using your DIS to try to identify HIV patients who are out of care and re-engage them in care, possibly pitch PrEP to patients and ask them to come to the clinic, that may generate costs that will be relevant for the health department to consider. And then also what we saw in the last couple of years when DIS tried to do COVID contact tracing, the numbers were large enough that things got overwhelming in a lot of jurisdictions. But the hope of COVID contact tracing was to notify people of their exposure so that they could get tested, isolate, potentially limit the spread, which would have cascading effects through the economy. And using a broader perspective, a societal perspective analysis might allow you to capture some of that to where it would be seen as justified to pay additional money, to have additional staff because you're realizing gains throughout the economy that maybe are not going to accrue directly to the health department. And then there are transmission effects from STDs. The DIS model was built around syphilis originally. Finding people when they're still in the incubating phase before they transmit, that provides a community level prevalence and incidence benefit. Incorporating that is helpful too, assuming you can model some impact of the cases that you reach. Those are just some of the ideas.
Great, thank you, Tom. There's also a question, and I'll put this to any of you to answer, about what's the best way to implement mentoring in a way that is helpful without with consideration of the current workload.
Honestly, has been a real challenge. Again, when the staff, when the workforce has been thin, it's been very hard to do those pairings. And I think as DIS workforces are smaller, the ability to take this DIS, put them with that new DIS, go out in the field together, certainly you lose some efficiencies there, but you gain development opportunities. I think I would welcome hearing from health departments from what has worked in your areas. Certainly, your good DIS, those DIS who just are always motivated, passionate, really care, and can do this for years and years and years, who are senior, who could, all DIS could use some change in the routine, but maybe potentially on a rotational basis, a DIS who's seasoned, who's strong, could be paired with new DIS. Okay, I'm going to spend a month in a mentoring role, and then it'll be rotated to someone else. It helps them develop. It gives them some different opportunities and responsibilities. And, every DIS has a different style, and you learn as a new DIS, if you work with 5 people, you'll pick up 5 different things that you like that they do that you want to employ. And I think that we all hope with the DI investments that there will be more opportunity to provide that mentoring, because there will be a little bit more depth in the DIS workforce and the ability to free people up to do some of that mentoring work.
Thank you, Dawn. There are also a number of questions asking about whether there's any ongoing research or evaluation of mentoring programs or other retention-related programs or cost analysis. And I think, Tom, you hinted at this by citing primarily a nursing study, but maybe you can speak a little bit to kind of the gaps in the research that you've seen.
Yeah, I think it is a definite gap. That being said, I don't have a comprehensive awareness of everything that's going on. There may be mentoring programs that are collecting good data that I'm just not aware of, but I think this is definitely something where we could use what I suggested, and I think my last slide, find success stories in some jurisdictions and use those as models to give other jurisdictions some insights into things that they might do to set up mentoring programs, structure them in a way that they would be effective, and minimize the drag time on other DIS duties, as one of the other questioners was alluding to.
There's also a question about if funds aren't available for salary increases, what are there creative alternatives that can be offered? What are some of the ways, aside from mentoring that's been discussed, to try to retain people?
So this is something, again, where if you look at other fields, you can look at things that improve the work experience, even if you can't offer additional money. Some of the nursing interventions have found that, even social activities like what many of us have in our workplaces, that can help improve employee engagement. But this is one area where health departments and government at all levels are often at a disadvantage. We have a limited ability to offer things like retention bonuses and additional bonuses to keep key staff. In private industry, they can do that if they recognize that someone is important to the workforce. They can usually find a way to get it done, and it can be a lot more challenging for government organizations.
Certainly. Thanks, Tom. We have another question for Dawn. Have you encountered any examples of things that jurisdictions are doing to help with burnout, fatigue, and even secondary trauma?
Yes, and I will admit at the front end, I am based in Chicago, so I'm very familiar with a lot of the great work that Chicago Department of Public Health has been doing, particularly in the past 2 years, as a lot of the DIS were supporting COVID case investigation, contact tracing. I'm sorry, Jen, could I have you just repeat the question? I want to make sure I'm
kind of, what are some of the things that you've encountered that are being done to address burnout,
sure,
secondary trauma, and the kinds of things that DIS are facing?
Absolutely. Thank you. Sorry, I appreciate you repeating. One of the things that we've seen in Chicago is, and you'll probably hear more about it, is the communities of practice that has been put in place for case investigators, contact tracers, and by extension also with STI, HIV, DIS, is a forum, an objective forum led by an external facilitator to talk through experiences. And they're not, experiences that people had with the trauma of the conversations that they're having with clients, but also experiences that they've had that were, surprisingly great, worked really well. It's also a teaching opportunity. Those forums have been fantastic for providing that support. And this forum where people don't have to take that stuff home with them, they still will take it home, but to a lesser extent, and, have to deal with it in their home lives. I know a number of health departments are becoming trauma informed. They're embracing trauma informed care and doing the work that they're doing. I think that's been huge. I've heard quite a bit around DIS being able to think through and approach clients from a different perspective, with a little more empathy, just understanding that there's so many challenges that people have that you just may not be aware of that factor into them being resistant or, rejecting what the DIS is trying to deliver, and with all good intentions. So I think there are a lot of great things out there. I think from COVID, we've learned a lot. Having the DIS workforce go into doing COVID work with their own experiences and recognizing the ways that CICT maybe could be done better from the lessons learned of partner services. So I think there's a lot of great stuff out there, and I hope there's more opportunities to talk to what other health departments have seen and have worked.
Thanks, Dawn. And several people have helpfully shared some information about things that they're doing in their offices. One is trying to reinforce DIS keeping the eye on the prize with the mentoring. If they're able to spend quality time supporting new staff, the new staff will be able to support the team and decrease overall caseloads once they're trained. And that's something that really helps this person's staff stay focused and engaged in mentoring. Another person said that retention has occurred because she was flexible with staffing and tried to place them with their strengths in their roles. She continuously listened to concerns and tried to meet halfway. She has a team concept with restructuring and values their input. She has lost some DIS due to COVID, but before that, they usually retired from surveillance. So that speaks to upward mobility as well. Another person said that sometimes having newer staff provides some initial training to the brand new staff is helpful because they have a good sense of what information would have been helpful while they were going through their own training, even if they might not be as experienced as more seasoned staff. Several other people indicated they also have mentoring programs active in their health departments. One other question that I thought would be interesting to ask, especially in the current environment, is in the era of telework, how does that influence mentoring of DIS?
I think the core of the mentoring is the same. It's just the delivery of it is you obviously it's not the same because you're not going out in the field with people. You're not you can sit in on a phone interview. I've always found that to be a little awkward, but you sometimes have to rethink through the delivery of it. It's not really the core goals of it or content of it. It's just and if you have, sometimes you have really great DIS who are really good in the field, really good with clients, but working in a technology setting is not necessarily their forte. So I think balancing the people who really are good and skilled at teaching others with the format in which that's delivered, sometimes that's a little bit of a dance that takes a bit of work. But there are a lot of systems out there that have some of these things built in where you can have three-way calls with clients, etc. But it is marrying the best of both worlds to a certain extent. And I know there are health departments out there who've started putting that in place and do that well.
Thanks, Dawn. Another one of the someone helpfully also added that they've had staff conduct virtual presentations to their new peers on individual topics of the work during this kind of telework heavy environment. I think another question that has come up, and I'll put this to any of you to answer, is whether there are lessons learned from other fields like nursing, EMT, other high stress fields that work with the populations facing also a lot of issues. Is there anything that we can look for there or learn from there around helping us with recruitment, hiring, and retention?
And what I have saw in my quick review of what has been done in the nursing field is that much with any job, if you can improve an employee's connection to how their job fits into the mission of the overall organization, a lot of times it's easy to get focused on an individual task and it's hard to connect that to a greater good. But to the extent that staff can do that, it gives them a greater amount of satisfaction for what they achieve. And then a certain amount of pain becomes a little bit more bearable. At least that's what the data show.
Thanks, Tom. I'm seeing now every other questions that we have are either questions really for CDC to ponder or repeats or related to other questions we've asked. So I'm going to close this Q&A session. Thank you so much to our three presenters, Julie, Tom, and Dawn. Thanks especially for stepping in at the last moment. We appreciate you. We appreciate all of your answers. Can I have the next slide, please? All right, I think it's up. So I'm going to introduce next Melinda Salmon, our next speaker, if she's ready.
Hello, yep, yes, I'm ready. Hi, everyone. My name is Melinda Salmon, and today I'll be speaking on challenges and possible solutions to DIS staff recruitment. I would want to be clear that I am suggesting possible solutions to many of the challenges we all face, because I recognize often the solutions are very unique to the specific project areas, and therefore what may work in one project area and the challenges you have in one project area may be very different from other project areas. And just if you don't know me, I came up as a DIS, and I currently work in DSTDP's Disease Intervention and Response branch and I oversee staff, DERB staff that are located on the East Coast in health departments, and I regularly work within the Philadelphia Department of Public Health as well. So just an overview of what I'm going to talk about today. But before I do get started, I want to acknowledge my colleagues, especially the staff in the health department in the STD control program. They assisted me with brainstorming ideas for this presentation and freely shared some of their most recent challenges to inform this talk. So my presentation today will include a pre-COVID case study, which illustrates the many challenges state and local programs have when trying to create DIS career paths. And this goes back even before COVID. Then I will discuss hiring for DIS in the current context. I will talk a little bit about attracting the right candidates for DIS positions and attracting qualified candidates. And then some of the many challenges we face with recruitment with working within state and local governments. And finally, I will talk about how we might look forward from where we are now. Next slide, thank you. So to illustrate some of the historical challenges in the recruitment and retention of DIS, I'm going to describe a situation in which a large jurisdiction in a large jurisdiction tried to revise their DIS position descriptions and create a career ladder for DIS within their program. For some history, this program had one DIS classification, so that a new employee entering and training to be DIS was getting paid virtually the same as an employee who had been there many years. In addition, the salary level for their DIS was lower than that found in many of the surrounding areas. So 2 committed staff members worked together with their human resources department to create position descriptions for 3 DIS levels. And that went, from trainee to senior DIS. And they also created a DIS supervisory position description. They had to work a long time to write up these position descriptions so that there was a clear differential in the duties and responsibilities for the 3 levels. And that whole process took about 4 months, writing out these position descriptions to the satisfaction of their personnel department. Once the paperwork was submitted to HR, they began waiting to hear the next steps. And after checking in multiple times with their human resources department, the human resources department finally revealed that they had lost the paperwork. So the entire process had to start over from the beginning. At the point when they finally, again, got the paperwork together, submitted it to the HR department, and the HR department reviewed it, the HR department indicated they had to do their own salary survey, which involved checking with other regions across the United States to determine DIS salaries in those areas. And this process took approximately 2 years. So when it all was said and done, they were somewhat successful, and their HR department did agree to the additional DIS level classifications. However, they decided to reduce the entry level salary and increase the DIS 2 level salary only by about $500 over what the entry level salary was. So if you're all moaning and feeling like you want to beat your head against the wall after hearing this story, imagine how the project area felt about their efforts. Next slide, please. So one of the speakers in the introduction talked about this a little bit. I think it was Julie Becker. So I also had this slide that talk about the Great Resignation. And this, some information I just got from doing a Google search was that, a record 4.4 million Americans left their jobs in September 2021, accelerating a trend that has been known as the Great Resignation. The number of Americans quitting has now exceeded pre-pandemic highs for 6 months straight. Employers, especially in low wage sectors, something else that Julie mentioned, are struggling to fill open positions. And one major driver appears to be that many workers are no longer willing to put up with the working conditions and pay accepted prior to the pandemic. Next slide, please. So, and at the same time, many people were quitting their jobs. The DIS market was exploding. More disease intervention jobs were being added to the job market as a result of COVID. And you can see here that I just did a quick Google search for DIS job vacancies, and I came up with over 3,000 job vacancies on Indeed. So, we have thousands of DIS vacancies, and at the same time, a DIS supplemental award, which provided additional funding to project areas to staff up additional DIS positions. So I think the question is, how might we ensure that we attract the type of candidates who see value in disease intervention work and who are qualified to do the job? And at the same time, how do we educate state and local human resources departments regarding the need to have flexibility in the hiring practices and the willingness to increase their flexibility regarding salaries, work schedules, and requirements for the position? So I'm going to talk a little bit about what some of my suggestions are. Thank you. So the first challenge I would like to discuss is attracting the right candidate for a DIS position. When I started looking at job postings, I realized that many of the postings did not really contain information about the actual duties of the job. For example, the opening line of a vacancy announcement I randomly brought up on Indeed stated, "The disease intervention specialist provides professional and technical services related to the treatment, control, education, and prevention of diseases." So just me, even having worked in this field for over 30 years, I would probably look at that and think, I'm not qualified for that job. So you can imagine if someone who has no experience is looking for a job, an entry-level job in public health, this might be a little bit intimidating. And also, of course, the vacancy announcements include the term DIS or disease intervention specialist, but I worry that people are trying to, people may even be intimidated by that job title, as well as the use of language like phlebotomy, visual case analysis, and investigation. And of course, although it may have gotten better, vacancy announcements in the past did not even contain salary information. So I think you really were perplexed about whether or not you should apply for this job. Is it way out of my range? Am I overpaid for what this job is, and that sort of thing? But I do think that salaries are now more likely to be posted with positions, which is good. Next slide, please. So some possible solutions to these issues are try to find opportunities to speak to candidates directly about the role of a DIS. I think if we can describe our jobs one-on-one with someone, it is much clearer what the person is expected and what the duties and assignments are. So obviously during COVID times, that's going to be a little bit difficult, but career fairs, I think, are a good idea. And I know many places now have virtual career fairs, or even presentations on college campuses or things like that, I think could be helpful in recruitment. And I also think, and I did a lot of reading about this, perhaps we should focus less on the roles of the position and more on the type of person who would be a good fit for the role. For example, someone who can think critically and someone who is not afraid to ask questions. Now, I do want to add a caveat into this, is that obviously we want to tell people from the get-go what some of maybe the less desirable aspects of the job are, doing field work and needing to be clear about the need to do field work. We don't want to gloss over those because it's very important that people understand that those are requirements of the job. Next slide, please. So some of the challenges I have seen when looking at job postings online also, and this is about attracting qualified candidates, is the need for a college degree to even apply. I think if a posting indicates a college degree is required, or even if it's preferred, I think many non-degree individuals won't even apply because they don't believe that their resume will get looked at if they don't have a college degree. Obviously, a low starting salary, even if there's a possibility for a raise after 6 months or a year, is not going to encourage some people to apply. And I think we all know some of the challenges with hiring teams that are reviewing resumes, and they are looking for very specific words or previous experience. And I think we probably should focus more on looking at the skills that their previous experience gave them, as opposed to looking for specific health-related experience or HIV, STD experience. So my suggestion is to de-emphasize college degrees and even public health experience when advertising these positions. While your ideal candidate may have a college degree, remaining open-minded regarding the types of people who are able to do a DIS job, I think will bring in more qualified candidates. Although it is difficult, I think it's important to be flexible with salaries, recognizing you probably do have a limit. During a time when the job market is highly competitive, being able to offer even an additional $500 may be enough to convince someone that this is the job for them. Also, I think it might be helpful to know in detail about the benefits of the position, such as 401k or retirement plans. These types of benefits may be especially attractive to people in mid-career or late career. So beyond salary, also talking about some of the benefits that the jobs have. And I think we should try to look more at the personality of the person rather than their previous experience or whether or not they have a degree in a preferred field. And just looking at things about, say, whether does the person seem naturally inquisitive, curious, or even nosy, as we know DIS can be. I think those are some of the good qualifications that we should look for when we are looking for candidates. Next slide. So the final challenge that I wanted to talk about was the need to work within local government's hiring rules. Often, the local rules just don't adapt well to DIS hiring or the DIS job. We know that hiring often does not happen quickly. There is not much to be done within a lot of these local systems. If you want to hire someone whose salary requirements may be slightly outside of the range posted. In addition, DIS need to have flexible schedules. You know, if there's an outbreak of syphilis among sex workers, having staff that can only work between the hours of 8 and 5 is likely not going to be a schedule that coincides with the working hours of those at risk. Next slide. So some possible solutions to this problem, and again, this is why I emphasize possible when I'm talking about this, is because I realize that, you know, some local governments are extremely rigid and some are more flexible. But when possible, meet with personnel staff to explain the challenges with hiring the DIS position. Is it possible for someone in the personnel department to spend a day with a DIS to understand the program needs? I think that is very eye-opening for people, and they begin to really understand why you need these flexibilities. If you cannot garner support within your local personnel system for the DIS requirements you need, you may want to consider using contracting agencies or other fiduciary agencies such as the CDC Foundation. Working with a contracting agency can grant programs the flexibility needed to work outside of traditional schedules, to offer additional salaries, maybe overtime, and things like that. Next slide. So now I wanted to shift gears just a little bit to talk about what we have experienced as far as trying to hire DIS staff in the post-COVID era. First, I think we have all seen or experienced an increase in visibility and awareness of the health department's role in controlling outbreaks because of COVID. And I think the public has increased familiarity with the role of contact tracing and what it does and its role in the spread of disease, and people understand the need now more for these public services. However, there are still challenges, especially when we are trying to hire in a COVID era. Our experience here in Philadelphia is that we have seen a decreased willingness for people to work in an office, and we are not requiring people to come to the office every day, but just on the days when they work clinic. Obviously, there is a need to come to the office to do data entry and things like that. And because our STD clinic is open, we do need DIS staff here. We know the best time to interview a patient is when a patient has been diagnosed. So we want staff, our DIS staff, to be available when our STD clinic makes a diagnosis. So many times there's just not an option to work from home. But as you all know, there is now an abundance of disease intervention related positions which do allow people to work from home. Much of the work is done on the phone. And now fewer and fewer people are willing to come into an office or to do field work when they can find a job that pays a similar salary but allows the work to be done virtually. But I hope that I can find a silver lining in this situation. With the increased number of people who are aware of jobs in public health and disease intervention, I think we will hire a lot of people, unfortunately, who will end up quitting within the first 6 months or a year. I was just in a meeting earlier today about this. Hopefully, within those many hires that we will do, we will find people who are committed and enjoy working with diverse population and understand the importance of personal one-on-one interaction. And those will be the people who stay on and hopefully can move forward and up in the field of public health. And that concludes my presentation. Thank you so much. I'll be available for questions immediately following the group's presentation. Thank you.
Thank you, Melinda. And before I get started, I just want to say that this has been a really some great presentations this morning, some very interesting questions, and I just appreciate the opportunity today to come speak with you about CDC's Public Health Associate Program. Next slide, please. So this is PHAP. We hire a new class each year. Some of the requirements that we have is a college degree, a bachelor's degree is the minimum required, and we require that people apply and be within 2 years of graduation. So what we get is typically a group of very motivated, very dynamic group of younger individuals that are excited to begin a career in public health. Currently, we have 370 PHAP associates located throughout the US and the territories. We have associates in both big cities, rural areas, as well as the territories, including Guam and Saipan. We currently have 183 first-year associates that just started their public health career in October of 2021, and 187 in the second year of the PHAP program, which will be completing the program in October of 2022. And the reason I mention that is because after an associate graduates from our program, we do everything we can to retain them in a public health position. What our evaluation data have shown over the years is that of the PHAPs graduating each class, about between 65 and 70% accept a job in public health, whether that is at their local host site assignment area, another assignment area in a different jurisdiction, or at CDC. Next slide, please. Just another picture of associates out doing their work. In 2021, we deployed PHAPs on 275 assignments to support the COVID-19 response. This included 143 deployments at the national level and 132 deployments at their assigned host site at the local or jurisdictional level. And I want to make note that a large number of the associates that we hire each year are in DIS assignments throughout the country. Next slide, please. So what is PHAP? PHAP is a 2-year paid competency-based program. For those 2 years, associates are federal government employees while in the program. And it's a partnership and a collaboration between CDC and the host sites. We have host sites that are state, tribal, local, and territorial health departments, as well as non-governmental organizations. And each year we have an open period where we accept applications from host sites, which is actually currently open now, and I'll be talking about that in a few minutes. And then annually we have a job announcement that to hire our class, which opens next week. And I'll be touching on that a little in just a few minutes as well. Next slide, please. So the PHAP mission is to provide training and experiential learning to early career public health professionals who contribute to the public health workforce. So really what that means is we assign all of our PHAPs to field-based locations throughout the US and the territories. But in addition to that assignment, we provide extensive training throughout the 2 years in 11 different competency domains that I'll speak about shortly. But it's more than just hiring and placement. We have a mentor program. Each PHAP that is hired is assigned a formal mentor that we maintain contact with, and the requirements that we have, each associate is required to meet with their mentor monthly. We think that's a vital part of their development over the course of the 2-year program. Next slide, please. And as I mentioned, we have different competency domains. And what we found is that by creating a robust training environment, it adds to the richness of the program, and hopefully in turn adds to the contribution that they make at the host sites. You can see some of the domains include public health science, analytic and assessment, program planning, management, and improvement, public health law and policy. We also have trainings on professionalism, communication. Most recently, we added a health equity domain to our curriculum. Community dimensions of public health funding, evaluation, public health emergency preparedness. And in addition to these competency domains that they take formal training in, we have monthly webinars that bring in current topics that might be going on. So for example, we have preparedness talks, we have COVID-19 talks, and we want to have a highly trained workforce as best we can, given the limitations that we all have. Next slide, please. Some of the benefits to the associates is they are a CDC employee with salary and health benefits. They develop, over the course of the 2 years, they develop transferable career skills, primarily learned from 2 years of hands-on public health experience, working closely alongside more senior and more experienced public health workers throughout the country. They receive both training at CDC at headquarters and in the field. Of course, as a result of COVID, we have shifted all of our trainings to be conducted virtually. They receive supervisory support. As part of our program, each public health associate has a CDC PHAP supervisor, as well as a local host site supervisor who hopefully work collaboratively to develop the best support system for the staff as possible. Excuse me. And as I mentioned earlier, we have a formal mentorship program that each associate is assigned a mentor within 30 days of being hired. And then really we think that the biggest benefit is just the valuable learning through the work experience. And we hope that that goes both ways, both at the host site as well as for the associate. Here's just a picture of some of the associates doing the emergency response. Associates throughout the years have been involved in all of the public health emergency responses. That includes Zika, Ebola, SARS, COVID, natural disasters, but also many have been used throughout the different programs that they work in to work on outbreaks such as syphilis, HIV, opioids, pretty much runs the gamut of all the responses that they've been on. And what we found is having a well-trained, ready workforce to respond has been a value to both CDC as well as the public health community across the nation. And next slide, please. So a lot of the conversations that have earlier from the presentations have been really addressing on, recruitment and retention. One thing I want to make note of, each year we open a job announcement for 7 days. We average between, well, the current average is about 2,000 applicants I receive each year. This year it opens January 18th and runs for 7 days. Over the years, we have had as high as 4,500 applicants for certain years. From that, we narrow it down and we conduct between 400 and 500 interviews with candidates to find the best candidates to fill these positions. And kind of the model that we've adapted is the best fit model. It's what we base our program hiring strategy on. We look for big picture thinkers, effective communicators, people that are socially and culturally inclusive, that thrive in a dynamic environment. They're flexible, intelligent, and tactile learners. And if you look at those kind of characteristics, they directly relate to a lot of the activities that are required to be a really good, strong DIS. We take great pain in our interview process, and it's a really big lift, but we really think that if we hire the right people, then we address some of the challenges such as retention and performance and things of that nature. In addition to conducting the 400 to 500 interviews, we also require, we call it a personal statement. Basically, it's a writing sample. We want to see that the candidates that we're bringing in have the ability to write effectively and communicate their ideas. It's a very small writing sample, but we routinely have about 1,000, between 800 and 1,000 personal statements that we review each year. So of the applicants that apply, we actually get on our hiring certificate somewhere between 800 and 1,000 viable candidates as determined by our CDC's Human Resource Office, and we have to narrow it down for there. Next slide, please. So most recently, we hired 183 new associates. They started their public health career on October 12th. And our largest supporter within the PAP program is assignments in our National Center for HIV, STD, and TB Prevention. So many of those assignments are directly related to DIS activities and support the STD, TB, and HIV programs respectively. Of the 183 hired, during November and December, even in the pandemic, we flew them to Atlanta. They received their official badges, some IT, computers and things like that, but also had them medically cleared and fit tested. So beginning in January, they were 100% available to do whatever's needed at their host site, whether that's their normal activities or respond based on their clearance levels. Next slide, please. And as I mentioned earlier, so we have associate assignments that range throughout public health, but the majority of our assignments are RN, STD, TB, and HIV. We feel that it is one of our core assignment areas and have an exceptional relationship with the center. And they provide us amazing support and are always supportive of our program. And it's amazing partnership. Next slide, please. So just kind of to show where our current class is. As you can see, we're a far-reaching program. We cover the majority of the states and the territories. We have people in Puerto Rico, Saipan, Guam, Hawaii, as well as rural Alaska, as well as many of our assignments. I mean, obviously, a big program like ours, the majority of assignments are in large metropolitan areas. One of the priority and focus areas for the next class will really be to maintain our presence in the large cities, but also increase our presence in a lot of the rural areas that are suffering health disparities and adverse health outcomes, and really have a low staffing level and difficulty recruiting qualified staff. We hope to be part of that solution as well. Next slide. And then kind of wanted to take a minute to just talk about hosting an associate. So as I mentioned, our program, the Public Health Associate Program, each year opens an application period. This year it's currently open, and it's been open for about a week or so, and closes in February. Next slide, please. And we encourage any host site that would like to apply. And we receive about anywhere from 200 to 300 applications a year. And we are looking to increase the number of applications that we receive, because we are going to be increasing our class sizes for the next 3 years to approximately a little over 200 each year. But we kind of view it as a three-legged stool concept of our goals. So hosting an associate, we hope that it provides a value-added service to the host site to help it meet its goals. And some of the assignments are, traditional public health programs like STD, TB, HIV, as I mentioned earlier, but we also cover a wide range of program areas, which includes, emergency response, accreditation, injury, you name it. We have associates that either currently working in it or we have worked in it. Kind of the expectations of a host site is that providing associates with experience in public health and service delivery, and then we try to ensure that associates achieve the PHAP competencies. Next slide. And then as far as being a host site is concerned, that's really minimal. We ask that the host sites pay for local travel and any local training costs, as well as provide workspace, telephone, and internet access, things of that nature, and then work closely with our public health, with our PHAP supervisors, to make sure that it's a win-win for not only the host site but also the associate. Next slide, please. Next slide. So I want to go ahead and put this up there. And for any of you interested in learning more about the PHAP program or becoming a host site, and I was looking at the list of attendees, we have a lot of people that host PHAPs on this call, so this isn't really new information. But the application dates for the host sites, they opened January 3rd and closed February, closes February 18th. And if you know of great people that you would like to refer, the application to be a PHAP opens January 18th and closes January 25th. And kind of on a little different note, so as I began to develop my presentation for this talk today, I reached out to our public health, our PHAP supervisors here in Atlanta that currently oversee all the associates, and just asked them to provide me some examples of TIS work that are being conducted by our current associates. And within 3 hours, I got 18 responses outlining just some amazing work that's being conducted in collaboration with the host sites, whether it was around contact tracing, surveillance, outreach. Some are being utilized to do COVID activities as well. but it just really showed that the flexibility that we've built into our program allows our associates to serve the need that's most pressing at your host site. And I did also want to mention that regarding retention. So in our program, we conduct evaluation activities with our associates several times during their course of employment, but we also do an alumni survey at 1, 3, and 5 years. And what we found about our retention is that it dwindles somewhat over time, but we still have a long, we still have a really high retention rate in the 60% after 5 years. And as far as life after PHAP, as I mentioned earlier, between 65 and 70% accept a job in public health. We have about 20 or so percent that go back to school to further their education. And at the end of the program, at the completion of their 2 years, and when our associates graduate, they have an option or an ability, if jobs are available, to convert to a federal position, which we have. I think last year we had 60 of our associates converted to a federal position, but we also have a number that stay in their local host site area. And as one of the resources that we have, we develop a resume book that we are happy to share with any of our partners for the graduating associates. Our resume book will be available in March of 2022. So if you're looking to hire candidates that have 2 years of experience and have transferable skills that have been developed over the course of the 2 years, and it's a potential option. And with that, I think I'm going to stop, and I'll certainly be here for questions. But I just want to, stress to everyone on the call that we at CDC, and particularly in the PHAP program, we would like to partner with any host site that we're able to, and just encourage you to submit an application. And if there's things that we can do, please do not hesitate to reach out, and would like to be a part of the solution, particularly as it relates to DIS. And as a complete side note, I've been with CDC 29 years and began my career as a DIS. So this is very important to me. And my daily job is workforce development, specifically, focus on hiring, recruitment, and retention. Thank you. And now I'd like to turn it over to Michael Castro.
Hi, everyone. Good morning. Thank you, Russ, for that presentation. As someone who's supervised and worked with many PHAPs in the past, if you haven't utilized the program, I highly encourage folks on the call to do so. They have been some really fantastic workers and great colleagues. So my name is Michael Castro. I use he, him pronouns, and I'm the Director of Disease Investigations for the Public Health Intervention Unit within the Bureau of Syndemic Infections at the Chicago Department of Public Health. Today, I'll be speaking on disease intervention specialist recruitment at the local level and some of the approaches that we've taken here in Chicago. As an overview, I'll be discussing our current models for HIV/STI partner services work in Chicago. We'll also talk briefly about our COVID case investigation and contact tracing model and the lessons learned through this work. We'll discuss some findings from the dissertation of CDC assignee Dawn Broussard. And lastly, we'll talk about the barriers facilitators lessons learned when it comes to DIS recruitment. Next slide. All right. So the Chicago Department of Public Health has an integrated HIV and STI program, and further, we're working to integrate the TB and viral hepatitis programs. Within the program I oversee, the Public Health Intervention Unit, we're predominantly responsible for conducting HIV and STI partner services. In this unit, we have developed specialized teams to conduct prioritized work, some of which include our congenital syphilis prevention team, who's responsible for conducting case investigations for clients who are sex assigned birth female of reproductive age. We also have an HIV response team, which normally would be responsible for working with clients newly diagnosed with HIV and conducting our data to care efforts. Unfortunately, due to current staff shortages, our data to care efforts have been put on hold. Lastly, we have a cluster investigation team who's responsible for identifying and responding to new HIV and STI clusters. Our current team consists of 9 DIS and 1 DIS supervisor. 8 of these 9 just started in December of 2021. So building on some of the comments made by Julie and Melinda earlier with the Great Resignation, we have lost quite a substantial number of staff over the past year. This leaves an additional 20 vacant DIS positions and 6 vacant supervisor positions. We also have additional, can we go back one slide? Thank you. We also have additional support staff, which include public health administrators levels 2 and 3 to provide higher level quality assurance, technical assistance, and managerial support, and 4 CDC assignees who support the public health intervention unit, as well as our surveillance unit. Next slide. So many of you already know the importance of partner services work, so I'm just going to skim over this slide. But partner services, as you all know, is a long-standing intervention that, on top of identifying infected individuals and notifying their contacts of exposure, provides a range of other medical, social, and psychosocial support to our clients. The goal of this work is to encourage positive behavior change and reduce HIV incidence. And the DIS title has largely been instrumental in this work and is at the core of this work. Next slide. So who is conducting partner services? In Chicago, we currently have 2 entities who do this work. First is the Department of Public Health, and second, since 2002, our federally qualified health center partner, Howard Brown Health. CDPH funds Howard Brown to conduct various services, including HIV and STI partner services. Howard Brown is one of the largest lesbian, gay, bisexual, transgender, and queer organizations in the country, and they have their own full-time DIS to provide syphilis and HIV case management for their clients. They also have limited access to our Chicago Health Information Management System, which many of you will know as Maven, to centralize documentation of these partner services efforts. The DIS here in Chicago, we call them communicable disease control investigators, support our clients by providing counseling, carrying out field visits, providing HIV and STI outreach, delivering presentations to community groups, performing phlebotomy for HIV and STI testing, and work with providers to ensure positive client outcomes. Next slide. So I do want to spend a little bit of time talking about the benefits to the CDPH and Howard Brown Health partnership. For CDPH, since Howard Brown is one of the largest reporting agencies within Chicago, the partnership has substantially helped in reducing the workload for CDPH DIS. The Howard Brown DIS are able to take on some of the cases that normally health departments would be responsible for. It has also helped strengthen the relationship between the 2 organizations to better facilitate communication and collaboration across all HIV and STI work, including outreach events and community engagement. Lastly, Howard Brown has less restrictions to using internet and app-based methods for finding partners. And prior to COVID, we were able to work with Howard Brown to provide support on CDPH clients using those methods. From a Howard Brown Health perspective, this collaboration has helped integrate partner services into the standard of care for all of their clients. Having DIS embedded within the clinics has facilitated a quicker turnaround time from diagnosis to the partner services interview, and it's usually happening the same day of presumed diagnosis. Additionally, because of its integrated model, clinicians are more invested in encouraging their own clients to disclose partners. Next slide. So with regards to STIs, what is happening in Chicago? So as many of you will know, similarly to increases reported nationally, Chicago is mirroring the increased trends in STI incidents. In 2019, we had over 32,000 cases of chlamydia, over 14,000 cases of gonorrhea, and over 2,500 cases of syphilis, of which 814 were primary and secondary. However, despite these increases in STIs, the volume of our DIS workforce has struggled. In 1993, we had 72 DIS, which dropped to about 40 between 1999 and 2006, dropped again to 20 in 2017. And given the amount of vacancies that we have right now, we are a very low number of DIS, but when we are fully staffed, we have a total of 30 DIS plus the additional support staff of supervisors, public health administrators, and CDC assignees. This is all to say that we need to be more creative with our recruitment efforts to combat the rising STI rates to ensure more clients diagnosed with HIV and STIs have access to this really important partner services intervention. Next slide. So briefly on this slide, we have the CDPH primary and secondary syphilis partner services outcomes for calendar year 2019 and 2020. As you can see, we're hovering around 60% of clients interviewed following assignment and have a partner index of 0.3. Unfortunately, I was unable to prepare data from our Howard Brown Health partner. However, in the past, when we've looked at their data and anecdotally their current data, they tend to have better GIS outcomes for their clients. This may likely be to the reasons mentioned earlier, having that fully integrated clinic model, interviewing being part of the standard of care, and clinician buy-in for partner services work. One thing that I think is really important is that this helps ensure that the client trusts the provider and makes the clients more receptive to the intervention. Next slide. Now, I'd like to spend a little time talking about our COVID case investigation and contact tracing model and the lessons learned from this work. So CDPH has provided case investigation and contact tracing, also known as CICT, since early 2020. And as COVID cases continue to increase, we needed to develop a multi-sector approach, which includes our CDPH employees, healthcare partners, and community-based organizations. Our current team works 12 hours a day, 7 days a week, and includes over 900 people. This model was extremely difficult to build. However, it did allow for more meaningful investments into the communities that we serve and helps create a more sustainable public health workforce for the future. As we continue to talk about retention and recruitment, they're so intertwined that it's important that we have this built out model of public health workforce throughout the city of Chicago. Next slide. So why did we utilize the healthcare facilities? Similarly to the HIV STI partner services model with Howard Brown, it was important for us to utilize healthcare facilities in our COVID work for parallel reasons. Reducing the workload on CDPH employees, faster turnaround time from diagnosis to case investigation to contact tracing, having consistency of one organization conducting all of the intervention, and then interventions being tailored to the patient populations being served. And again, what I find most important is that client trust and rapport with their established provider. Next slide. So on this slide, I briefly just want to show the Chicago COVID CICT model in action. So if you look at the upper left-hand corner, you can see upon positive COVID test, if the diagnosing facility has contact tracing abilities, that organization will conduct the case investigation. If the organization also has contact notification capacity, they will also provide that service. If the healthcare organization does not have contact notification capacity, they'll work with one of our CBO partners to do that work. And for all other work that cannot be supported by the healthcare facility or CBO partners, that will be conducted by our CDPH team. So having that strong collaboration between health department, healthcare organizations, and community-based organizations has been instrumental in making this such a successful model. Next slide. So this will briefly show some of the COVID CICT outcomes. I apologize for the formatting, but that just says Chicago COVID CICT outcomes. What I do want to highlight is the difference in successful interviews by the organization type. And as you can see here highlighted, healthcare organizations were able to successfully interview 60.5% of the cases assigned to them compared to the 35% of cases assigned to CDPH, which indicates more successful outcomes. Next slide. Next slide. So switching gears a little bit, I do want to discuss some findings from an analysis conducted by CDC assignee Dawn Broussard titled Framing a Future Vision of Partner Services. This was a case study of the CDPH Partner Services Program, looking at the current barriers and facilitators to partner services work and exploring how we can inform an ideal future state of partner services. This was done by reviewing our current documents and interviewing staff from frontline workers, so GIS, all the way up to program leaders. Next slide. The research questions asked during the study were, how do public health officials characterize the current state of partner services and what are current priorities? How do public health officials define success and what are the current barriers to facilitators? What is valued about partner services? and help my partner services programs be better aligned with perceived value. Next slide. From this analysis, Dawn came up with 5 key recommendations. However, for this talk, I do want to focus on just 2. The first is to develop the disease intervention workforce. As many of you know, DIS work is hard, and particularly during these past 2 years. As public health leaders, we invest a lot of time and resources into these staff upon training. However, as mentioned in earlier presentations, we often struggle with retaining staff due to burnout, and unfortunately, due to slow government processes and HR processes, we can't backfill these staff quickly. And the time it takes to train new staff is also very cumbersome. What is recommended here is to make sure we're advancing DIS as a professional series where there are clear paths for staff to grow within the organization. I feel that not only helps us retain good staff in our organizations, but also can be used as a recruitment tool to market this position as a professional growth opportunity. Further, we can implement cross-training and practices across multiple conditions, which expands the scope of DIS work. As we all know, DIS are situated across many programs throughout health departments. If we are able to cross-train these staff, they can be utilized if and when we have an outbreak or increased incidents in other programs. And lastly, instilling self-care and burnout prevention into standard DIS practices is instrumental. We don't want to keep running into this retention and recruitment challenge where staff get burnt out and move on, and then we are back at the recruitment stage where things take a long time to process through HR departments and get folks trained. Here in Chicago, and as Dawn mentioned earlier, we have weekly communities of practice where DIS are able to vent their concerns and discuss challenging cases. And this has been overall successful in our Chicago model. The second recommendation I want to talk about is expanded community partnerships. So as we see with DIS outcomes from our Howard Brown Health partnership and the COVID CICT model, furthering partnerships with trusted agencies that serve those disproportionately impacted and or those that identify substantial numbers of cases can have significant impacts on DIS outcomes. Also, joint planning with community partners can be utilized to overcome obstacles and increase uptake of the intervention. That being said, partnering with these community partners will not erase the need for DIS within health departments. There will always be a need for health departments to continue partner services work, particularly for providers who do not have the capacity to do this work on their own, and also to provide ongoing support and TA to those who are able to establish their own partner services workforce. Next slide. Lastly, I do want to spend some time talking about the barriers, facilitators, and lessons learned from our current workforce, the partnerships with Howard Brown, and our COVID CICT model. And lastly, the findings from Dawn's analysis. So with barriers, as many of you know, working within government agency can be slow, and particularly with recruitment and hiring. We also experience high staff burnout and turnover, which has only increased in the past year with the Great Resignation. And lastly, since many DIS are in unionized positions, this creates a unique challenge where staff can transfer to other programs utilizing the same title. Because of these reasons, we must be creative in how we recruit a more sustainable workforce, so when we do experience staff shortages, we're still able to deliver effective interventions to the clients that we serve. Next slide. Some facilitators to DIS recruitment here in Chicago are one, the financial compensation. So in Chicago, we have a starting salary of $52,896 with built-in salary increases. This makes these positions more attractive to the candidates who are applying. Second is to advertise and put on applications the Federal Student Loan Forgiveness Program. This is a program that for folks who have certain federal loans can have their loans forgiven after 10 years of public service. And I think that by utilizing this in our recruitment strategy, we might have better candidates applying or more candidates applying. Additionally, as we learned from our partnership with Howard Brown and through the work of COVID CICT, these partners usually have much more flexibility in hiring their teams with less stringent administrative barriers. Lastly, thanks to the PEACH supplemental funding, we were able to budget for more DIS and supervisors with plans to train this cross-cutting workforce that I mentioned earlier. This will help in two ways, is one, having more bodies to do this increasing work, and two, by developing that cross-trained workforce, we're able to quickly pull folks to areas of highest need when we do experience shortages. Next slide. So to discuss some lessons learned, I want us to remember that it's important to know that partner services work conducted in HIV programs, HIV and STI programs, and other communicable diseases can be different. And this speaks more to the need for training a cross-cutting workforce. There's substantially higher volume of HIV and STI cases, and second, having conversations around HIV and sexual health can be more challenging for DIS than, say, talking about a respiratory condition. Again, this furthers the argument for developing that cross-trained DIS workforce that can support various programs in times of need. I think this also supports our recruitment efforts in saying that we're able to train them across multiple conditions rather than them being siloed into one condition. We must also learn from the successes of our Howard Brown Health and COVID CICT models, where collaborating with healthcare organizations and community-based organizations can provide a unique opportunity to expand the DIS workforce and reduce the burden on health departments alone. By working with our funded healthcare organizations to expand partner services, we also support recruitment of DIS that are more representative of the communities that we want to serve. And finally, training DIS to be more diverse and responsive will help us fill gaps in service when they arise. Next slide. So before I end, I do want to just acknowledge a few folks that helped make this presentation happen. David Kern, our Deputy Commissioner, Irina Chibidze, our Director of Program Operations, Don Broussard, Senior Public Health Advisor, my Public Health Intervention team. Without this, I wouldn't have anything to present. Howard Brown Health for their continued support, and finally, our COVID CICT team. That concludes my presentation, and I'd like to introduce next Jamie to coordinate the Q&A section.
Thank you, Michael, and thank you, Melinda and Russ, for your excellent presentations. Before I get into specific questions, next slide, please. Sorry. Before I get into specific questions, I just wanted to note that we are recording today's session, and it will be available a couple months after the end of the session. I know folks have been asking about that, so I wanted to let you know. My first question that we received is for Melinda. The first question is, what are the best practices in increasing HR personnel's understanding and awareness of the importance of the positions, DI positions?
Well, one of them, and one of the things I mentioned quickly is, if you have an opportunity to have your personnel staff, spend a day in the life of a DIS so they can understand that priorities are constantly shifting. You may have had your day set up, but then your supervisor says, oh, we have this pregnant female, and from what we've heard, she's working, so we need you to go out late in the day. They can, and then understand the need to go to the field, and often in neighborhoods they're not familiar with, or with high crime rates. I think that can be incredibly eye-opening to staff and personnel departments who haven't had that opportunity in the past to really see what the work is all about. So that is definitely one thing that I would suggest. I think just having conversations too, just starting the conversations going and letting them really understand, this is not just a job description. These are people in these jobs, and this is what we're dealing with, help them understand like the rising rates of congenital syphilis and why it's a priority, and why we have to have staff that are nimble and sometimes have to work overtime, and those sorts of things, I think, hopefully would be helpful. I don't know if there are like really published best practices on this, but I'm open to hearing from others as well if they have any ideas.
Okay. And as a follow-up, what might be some disadvantages of doing away with education requirements for DIS?
Well, I think, just my experience has been, just as we cannot assume that everyone who has a college degree has competencies in some areas, we can't assume that people without college degrees don't have competencies in some areas. I think In some situations, people with college degrees are more likely to have more critical thinking skills. But I do think that we miss opportunities to have great employees if we even say college degree is preferred. One of my best employees ever did not have a college degree and was an amazing writer and critical thinker. So I just think, as with all things, we need to have an open mind and look more at the personality traits of the individual rather than what we may set as qualifications or experience.
Thank you. My next question is for Russ. What sets PHAP associates and alumni apart from other early career public health professionals?
Thank you, Jamie. I think the big factor that kind of sets the PHAPs apart is because of the 2 years of experiential training that they've really received. What we know from our workforce is, they need ongoing training, they need development, they need, classroom, but the real thing that sets them apart is the day-to-day working knowledge that they get from working at a local jurisdiction or a state health department or an NGO. I think that's what really provides the value after they complete the 2 years for them to be a ready workforce to be picked up either at the local or the federal level.
And there were a couple of questions about the education requirement. So someone asked if these programs were offered through 2-year community colleges, and also if you know of any programs available for those who haven't recently graduated from college.
So that's a great question. So currently, CDC doesn't support any program that has a lesser requirement than a bachelor's degree. We have started a pilot program in the territories, not PHAP, but a PHAP-like program that we're working to establish that is a 2-year level program, because they have the same issues that we have in the territories with a lack of, people that are available to hire, but theirs is even more so. So they've lowered the educational requirements and have developed a pilot program. But I am not familiar with any that require anything less than a bachelor's degree.
Okay, thank you. Michael, we have a question for you. So how can we recruit a more diverse DIS workforce that better represents the communities we are trying to serve?
Yeah, thank you for that question. I think there's a few ways that we can approach this. I think one is making sure that our organizations don't have structural issues that prevent communities of color and people of the LGBT experience to apply to our organization. For example, for trans folks, it may be challenging to apply to a position if the application doesn't provide an opportunity for them to list their chosen name and only allows them to list their legal name. So looking at our HR policies and application processes to make sure that we are not causing structural issues, preventing the communities that we want applying for these positions. I think secondly, we should also leverage our healthcare partners and community-based organization partners. We have these great connections with people that work in our communities, and we should leverage them when we are posting positions to refer candidates that may be a good fit for our programs. And then, as I mentioned throughout the presentation, if it's possible to build out that DIS workforce within the healthcare organizations, that's a really unique opportunity to expand the DIS workforce beyond the health department intervention. And they have more flexibility in recruitment and hiring practices that they can leverage.
Thank you. I have one more question that I believe was for you. Are the embedded DIS health department employees or HBH?
They are HBH, they're Howard Brown Health employees. So we provide funds to Howard Brown Health to provide certain services. And one of those services is HIV and STI partner services, but they do hire their own staff that are DIS that work within their own clinics.
Okay, thank you. The next question is for Melinda again. So what might be some avenues or venues where health departments could promote DIS openings to people who have done COVID CICT work?
Well, I think, working with your COVID department and within your health department, I know COVID hiring has gone up and down, and that's been a challenge, I'm sure, as the waves of COVID have increased and decreased. but promoting it again within your own health department for staff who may be interested in leaving. I think Indeed always has, that seems to be a great place for people to advertise positions, as you know. There are many contracting agencies, and we are working in Philadelphia, the managers here are working with something called Career Link, which is another avenue just for reaching people who may not go on places like Indeed and places like that. It's an avenue to help people find jobs. So I just think thinking maybe a little bit more outside the box than what we've been accustomed to thinking, which worked great in the past. It's just now, you know, we're having a lot of different struggles with finding people who are willing to do field work, meet with patients face to face. I mean, we have a large conference room where we do our partner services interviews now. You know, someone sits at one end of a long conference table and another person sits at the other end, but you still have to wear a mask, and people just don't want to do that. But I think we have to get creative about reaching people who are going to be willing to do this work.
Okay, one more question. Do you think it's necessary for an initial 6-month training for DIS in order to completely grasp the concept? And if not, maybe more shadowing and more detailed software training may be useful.
So these questions are so pertinent to many discussions that I had just this morning with my colleagues here in Philadelphia, because we were talking a little bit about switching up the training to a degree and doing some initial training, maybe just around gonorrhea and chlamydia, and then having people start to do field work, because where we're getting a lot of pushback is people do not want to do field work. And we don't want to go through all the training regarding syphilis because that's more intensive, and teaching people visual case analysis can be complicated sometimes. And then find out later that, you know, what their real issue is going into the field. So I think maybe it's, you know, I think you have to look at your own program and see what works for you, but we're considering doing some things a little differently here, like doing gonorrhea and chlamydia, letting people get some experience doing field work. And then if they stay, you know, past the 6-month part, then teach them more about syphilis and the visual case analysis and things like that. And then after year 1, people do get a salary increase, assuming they've met all the minimum requirements. So that might be more of a retention effort as well. So we're considering a lot of different things, trying different things and see if they work. I think that's what we have to do because we just don't know.
Okay, thank you. The next questions are for Russ again. So how can my health department get involved in PHAP, either hiring associates or recruiting an alum to work at the health department after they graduate, and what kinds of resources are available for this?
Thank you. So primarily, we really are, I want to extend my sincere invitation for any jurisdiction to submit an application to host an associate. We really feel that it's a great program to bring people into public health, and we have some evidence to show that we have retention over the years. And we provide technical assistance. If people need assistance with submitting applications, they can reach out to the PHAP website, which is just www.phap.cdc.gov. And that's one avenue. So the second avenue is if you're looking to hire experienced staff with at least 2 years of experience, I will share the resume book, Jamie, and maybe you can distribute it to the group when it comes out in March. So we have every year we have a host of qualified candidates that are looking for positions, some locally, some in different states. But the resume book that we put together is a really good resource that we provide that, you know, you get their resume, you get the experience they have, you see what subject area they've worked in, and it could be a valuable resource for you to hire staff, but also for the associates to gain, meaningful employment after their 2 years with PHAP.
Okay, thank you. And do PHAPs get redirected to other states or territories in an emergency, or do they respond for the local host site in an emergency?
So we actually have a combination of both. Depends on what the emergency is. And if we have a PHAP that has a unique skill or something that's really necessary that is needed in another jurisdiction, we have deployed them for a limited time We have a rule of we won't deploy anybody more than 60 days during the course of their 2 years. But we kind of do both. But more times than not, when we need associates to be deployed, we do it within their geographical area. But the majority of deployments are actually interjurisdictional. So we have somebody working in the STD program and there's a huge outbreak, we're able to redirect them locally.
Okay.
Over.
And the PHAP classes, are they online?
So we utilize CDC Train. So the vast majority of our classes, our training classes, are online. And after this presentation, I'm happy to send a list of the courses to you if you'd like to share with the group as well. So over.
We have a few questions for Michael. I think we're okay with time. Okay, so what training at CDPH did you utilize to train your DIS partners to provide DIS work for STIs, COVID, and HIV?
Yeah, that's a great question. Unfortunately, right now it has been a little bit of a hodgepodge of training. We have utilized CDC Train quite a bit, and the Johns Hopkins COVID training. We are currently working on building out a training center for Chicago's Department of Public Health. So more to come on that in the future, but utilizing what's available right now and also building in hepatitis and tuberculosis training was key to developing this cross-trained workforce.
And can you expand on what HR difficulties CDPH is experiencing? It seems to be a common problem in hiring staff in many jurisdictions.
Yeah, so I think that there's a couple of things. I think one is that these HR processes are long and complicated, sometimes unnecessarily so. During COVID, I think what has happened is that the stress of the pandemic and a lot of staff resigning from their positions has really shown a light on those processes, and we're currently working to look at and address those processes. The other issue that happened over the past year was that since COVID took such a high priority, it did delay hiring of many other positions in our program.
Okay, and there's a question that came in. It's probably for both you and Melinda. With affirmative action and experience-based hiring practices, how do you recommend recruitment efforts that focus on skills needed for DIS rather than experience and college degrees?
So I'll go first, and then Melinda, feel free to jump in. In our current round of interviewing, as we're looking to develop or to hire this cross-cutting workforce, what we've done is somewhat of what Melinda has already suggested. Not looking so much at the specific skill sets. Of course, it would be a great bonus to have people who have HIV and STI experience in our program, but really looking at that customer service skill, being able to be conversational and receptive to really difficult topics and being comfortable being uncomfortable. So looking for those skills while we're interviewing has been really important for hiring our new cohort.
And Melinda, do you have anything to add?
No, I think Michael covered it all. Yeah. I think we do, because that's going to require a shift, I think, for everyone when, looking at resumes and things like that. Because in the past, we have really looked for maybe HIV testing experience or HIV counseling and testing experience. And I think we're just going to have to start thinking differently. These are entry-level roles. The job market is very tight now. And there are people out there who really don't have any idea about what a DIS does. So we have to sort of expand what we find as acceptable experience. I'm not sure if that answered the question that was sent in, but I'm not familiar with the term. What was the term you used, Jamie? Experience-based?
Yeah, experience-based and education. So having the college degree requirement.
Yeah. Again, I think it's just going to be a shift in the way we think about who is appropriate for these positions and expanding what we think. I don't like to talk about this so much, but when I got a job as a DIS, I was an English major. I had no clue what I was going to do with that degree. And I saw this job and I was like, this job is perfect for me. Well, that was obviously many years ago. before people knew what public health really was. I mean, public health has really grown as a college degree and as a career since then. But I just think that there are people out there who perhaps this kind of job just wasn't on their radar. So if we get applications from people like that who hear about the job from some people, from someone, or hear, someone talk at a career fair, we should be open to looking at those resumes and speaking with those individuals.
Thank you, guys. And I want to thank the three of you again for your excellent presentations. Next slide, please. So the final section today is DIS training, and our first speaker is Glenn Christie.
Thanks, Jamie, and hello, everyone. My name is Glenn Christie, and I'm the Chief of the Disease Intervention Response Branch here in the Division of STD Prevention. And my presentation is going to be on current training programs for DIS. Next slide, please. I will discuss how identifying training needs contribute in developing training for the DIS workforce. I'm going to talk about considerations and approaches in training DIS and CDC's role in DIS training and development. I'm also going to provide an update on trainings currently being developed, as well as those that are planned, and share some of the resources we have made available to assist programs in training their staff while waiting for the new DIS foundational course. Next slide, please. So you heard from an earlier presentation how the lack of a formal education requirement that other professions have in place makes DIS profession unique. And given the work that they do and the significant responsibilities they have, DIS perform prevention and controls activities across multiple infectious diseases and are frequently called on to support responses for infectious disease outbreaks, other public health emergencies, and pandemics such as H1N1 and the current COVID-19 response. DIS training should provide skills transferable beyond STD and HIV to develop investigative skills that are necessary to perform the duties required when mobilized for these emergency responses. And training needs assessments are conducted by a variety of stakeholders, including jurisdictions themselves, training providers contracted by some jurisdictions, and the training centers that are funded by us here at CDC. Training needs assessment should inform the focus and content of trainings. And trainings that are developed based on these needs assessment should support the core competencies outlined in the DIS job task analysis that was completed during the National DIS Certification Feasibility and Assessment Project a few years ago. Jurisdictions will also need to use what they learn from assessments to develop training that are tailored to their local needs to augment that national training that their DIS received through our programs. Next slide, please. So what are some considerations for training DIS? A comprehensive disease intervention training program should cover the full spectrum of knowledge, skills, and abilities needed to successfully perform STD and HIV disease intervention activities. And that includes fundamental skills for disease investigation and partner services, and disease-specific information to support public health follow-up of STD, HIV, TB, viral hepatitis, and other infectious diseases. And DIS training should also incorporate coursework that will develop those cross-cutting competencies that you see listed here in the slide that are essential for their proficiency in performing their duties. The hyperlink in the slide will take you to the final report for the DIS certification project for more information on those core competencies. Next slide, please. A comprehensive disease intervention training program should be inclusive of both national and jurisdictional specific training and cover the full spectrum of knowledge and skill and abilities needed to successfully perform those disease intervention activities. We also realized that addressing those training needs include providing training that enhances the knowledge and skills of their DIS supervisors as well. And later on in the presentation, I'll show what we're planning to do to help addressing training needs for supervisors. Next slide, please. Training the DIS workforce is a partnership. It's a partnership between public health programs at different levels of the government and with their private sector partners. CDC works with the training centers that we fund to develop and deliver training. And our training center network consists of the National Coalition of STD Director as our online curriculum development training center. The University of California, San Francisco is our instructor-led curriculum development training centers. And we also fund 4 regional training centers for training delivery. In Region 1, which covers the Northeast, we have the Health New York Training Center. In Region 2, we have Healthcare Education and Training Incorporated, a training center providing service to states that surround the Great Lakes. In Region 3, Denver Public Health Training Center provides services to states mostly in the southern region of the country. And UCSF in Region 4 covers the western states, Alaska and Hawaii. Jurisdictions pursue various approaches to augment trainings provided by the training centers to meet requirements that are specific to their localities. Some hire their own trainers, while others rely on supervisors or peers for on-the-job training and monitoring of training progress. And some of the presenters earlier talked a little bit about some of these programs that jurisdictions are employing. Effective training programs incorporate a variety of methods to train DIS. And it's not enough, for training to provide information about diseases and how to conduct case investigation and partner services. It's important that the training be designed to include both knowledge and skill development training sessions as appropriate to allow for practice of some of the principles the participants are learning. Many jurisdictions also employ mentoring or coaching in their training program and peer-to-peer learning, such as job shadowing. Next slide, please. So CDC's role in DIS training and development is to provide national leadership in applying the science on diseases, the knowledge of the evolving responsibilities of DIS, and emerging public health practices into developing training that strengthen the capacity of state and local health departments to provide STD and HIV disease intervention services. Doing so requires collaborating with applicable programs within the agency as we partner with our training organization, such as those in our training center network, and also with health departments who use the training to ensure they have a competent workforce. Also important is the funding we provide to develop national trainings and the funding provided to jurisdictions to pursue effective approaches in both assessing their workforce training needs and providing training or access to training to meet those needs. Next slide, please. So there's a great deal of interest in what trainings are being developed and when those trainings will be available. Some of the recent funding that we received under the American Rescue Plan Act for investment in the DIS workforce was targeted to support DIS training. To facilitate making additional trainings available as early as possible, we did fund 2 additional curriculum development organizations to help us develop these trainings. The regional training centers that are a part of our training center network will be hosting general disease intervention learning collaboratives on topics that include working with people who use substance, disclosure counseling, field safety, and a cultural humility session focusing on working with men who have sex with men. And these learning collaboratives will be a 90-minute interactive session that are expected to be available in January of 2022. Our training centers are currently developing a new DIS foundational course. The new course, which we've called Principles, Practices, and Pathways to Disease Intervention, or 3PDI, replaces Passport to Partner Services, and we anticipate it will be available in the spring of 2022. Now, this training will include self-paced e-learning modules and an interactive virtual skill-based classroom session, similar to what we had in the old Passport to Partner Services. The skill-based interactive sessions will be about 40 hours. Given the demand for the new course and to facilitate as many people as possible completing both the e-learning and instructor-led sessions for 3PDI as quickly as possible once the course is available, we are planning to offer more instructor-led sessions than was originally intended. We're planning to provide additional STD surveillance training that we envision will be provided both through e-learning and instructor-led sessions. And we anticipate that these training will be available in the summer of 2022. Our branch, the Disease Intervention and Response branch, worked with a training developer to complete the pilot for a coaching program for DIS. Earlier in the different presentations, we heard mention of mentoring programs and so forth, and we hope to contribute to the effort here of applying mentoring as a way of helping to develop our workforce. During the pilot, there were 2 cohorts of experienced DIS staff that were trained, and they provided feedback to refine the material to use to develop the program. The first cohort consisted of current staff here in our branch, and the second cohort were made up of DIS from state health departments. We plan on using the material from the pilot to create a national program that we anticipate will be available by the fall of 2022. Next slide, please. Other trainings we're planning to develop include a molecular cluster and outbreak response course to enhance DIS role in response to clusters and other communicable disease outbreaks. A training series on working with key populations, improving interaction between DIS and key populations as an essential tool for communicable disease prevention and control. We're planning to develop a course to improve DIS knowledge on enhancing community and provider level engagement. And we are also developing a program for supervisors. And this supervisor program will incorporate updated elements from previous supervisor courses, and it will include e-learning as well as instructor-led sessions to provide a well-rounded training. It's too early for me to provide details on the availability of these training beyond the year shown here in the slides. However, my next slide, I'll discuss how we will provide updates on the trainings being developed. Next slide, please. We know there's a demand for training. Many programs are working on rebuilding their DIS workforce, and that's especially true of training to develop those fundamental skills that new and or inexperienced staff need. And to assist programs during the development of 3PDI, we have posted a DIS training plan on CDC Train. Now, these plans focus on fundamental skills for new and or inexperienced DIS, as well as others who are conducting case investigation and partner services activities. The plans include modules with courses on general public health topics, gender diversity and cultural competency, disease investigation, outbreak response, and courses from Passport to Partner Services. In addition to the plans on CDC Train, we have updated the division's DIS webpage. The updated site provides information on DIS courses and webinars, along with other resources that can aid in training. This is also the site we'll use to direct people for updates on the development and announcement of the new trainings. We'll work with our project officers, colleagues here in the division, as well as the National Coalition of STD Directors to announce these updates through their communication networks as well. Next slide, please. There are also COVID-19 trainings that are currently available that can help develop DIS. 2 of the CDC-funded COVID-19 skill-based courses on conducting case investigation and contact tracing allows participants to practice interviewing, notification of exposure, and other communication skills. And although these courses lack a sexual health component, they can still be helpful in training DIS. A virtual instructor-led COVID-19 leadership course was added for public health leaders who manage case investigators and contact tracers. And some of the leadership skills taught in the course are transferable to leaders who are managing DIS in STD and HIV programs. And there are also learning collaboratives on COVID-19 topics that DIS who are currently supporting the COVID-19 response are encouraged to take. Next slide, please. So this concludes my presentation, and I turn it over to the next presenter, Dr. Sarit Galut.
Thanks so much. Thanks so much for having me today. I'm really honored to have been invited to share some thoughts as part of these important conversations. And before I start, I just want to acknowledge that many of the points I'm going to make today were also informed and refined by conversations that I had with Glenn Christie prior to this meeting. And I'm really grateful for those insights. And also by my collaboration with DIS colleagues in New York City. I want to raise up in particular Chichi Udiagu, who's the Strategic Director of HIV Partner Services and the Data to Care program at the New York City Health Department. And she's a brilliant and passionate and visionary implementer of DIS work. So in listening today, one of the themes that I've heard a lot so far is the need for practical action steps that both CDC and local DIS services can use to support their workforce. And the different types of support that I've been hearing are both supporting the quality of work directly with clients and also supporting the quality of staff's own experience, increasing meaning and fulfillment and decreasing burnout. And so what I tried to do in preparing remarks for today is think about the perspective that I might bring to this conversation as someone who's not a DI specialist, but somebody who could potentially add value as a psychologist, an implementation science researcher, and a staunch and passionate advocate for health equity. And I've been looking at the questions in the Q&A during this session, especially about sort of like this tension between moving forward on what we already know and continually saying that more research is needed or more models are needed. And full disclosure about sort of where I stand on this tension, I think that we know a lot about what needs to be done. And that part of the challenge is whether or not we have the ability and the will and the tenacity and the support at the federal level to actually be able to implement it. So from these perspectives, I think there are several key lessons that can be incorporated into enhancing and expanding training programs. And these lessons are about both content, meaning the content that's covered within DIS training programs, and process, meaning the way in which DIS training is organized and implemented. And so I'd like to start with an analogy that encapsulates what I think is some of the most important and pervasive findings that have come out of psychological research on human behavior. Next slide. This is an analogy that was coined by Dr. Daniel Ariely. And Dr. Ariely argues that encouraging and supporting a given behavior is like launching a rocket ship. You need to provide fuel and you need to reduce friction. And so in this analogy, fuel is motivation. We need to motivate individuals to want the interventions that we're offering. And I think that this is something that DIS workers, supervisors, and program directors know very well. Next slide. And I know that DIS training is very focused on strategies to enhance this motivation. And Glenn just mentioned several important, what you guys call cross-cutting competencies that are part of training already that I think directly relate to this provision of fuel: culture of humility, active listening, motivational interviewing, situational awareness. But the challenge, which I know you're all aware of, is that developing these skills is hard. And for most of us, they take time to really develop and master. And so I might suggest that in addition to working on developing these core competencies, some DIS training and protocols might consider providing specific language that DIS staff can draw from immediately in working with their clients that are based in the psychological science of motivation. Because the psychological science of motivation suggests that specific language, meaning the specific words that are used by interventionists to describe behavior and to actually describe programs as well, can have a tremendous impact as either fuel or friction. And I actually went into a lot of detail about this type of language that could be used with clients in a talk that I gave as part of the STD Prevention Science series back in September. So I'm not gonna sort of repeat that all here, but I just wanna remind you of the two most important categories. Next slide. The first is language that reduces reactance. And I'm sure you're all familiar with reactance. Reactance is a motivational state, actually, in which some external stimulus, a health message, an interaction, a request is perceived as constraining options and limiting autonomy. And the key here is that reactance results in both negative affect and also negative cognitions. And I think that we're all familiar, especially right now, with the role of reactance in disrupting health behavior. But I think what might be less widely known and certainly less widely utilized is research on specific language that has been demonstrated to reduce or diffuse reactance. Next slide. Which includes specifically choice enhancing and agentic language, restoration postscripts, meaning after you say a certain thing to a client, restoring choice to them, provision of alternatives in working with clients, and the use of a narrative as opposed to didactic style. And I think that even just providing sample reactus reducing phrases and language could potentially be an extremely helpful tool for DIS training, as can the second category. Next slide, please. Which is language that activates positive cognitive frameworks. And I think that the two most relevant cognitive frameworks for DIS work are self-affirmation, which is the process of reflecting on and reinforcing our most important overarching values, and self-efficacy, which is an individual's belief in their own ability to engage in behavior, not only to engage in the behavior itself, but to engage in behavior that will actually have a positive impact on their lives. And again, I think that there's specific language that could be used with clients to provide opportunities for self-affirmation and enhance self-efficacy. Next slide, please. And my recommendation would be to integrate this type of language into DIS scripts, which can be used effectively even as people potentially are gaining and building some larger core competencies. because they have the potential to significantly impact this fuel that we are providing to clients for behavior change or intervention acceptance. But I want to say that an equally important role of language for fuel and friction is not just language that is used with clients, but also language that's used about clients and about programs. And this is something that I think about a lot in my programmatic work in New York and also across the country, specifically in the Southeast. So consider the following contrast. Next slide, please. Our program targets specific populations in order to overcome hesitancy, mistrust, or ambivalence, versus our program focuses on what might motivate, support, and inspire individuals toward action. And I think a lot in public health, traditionally, we are taught to think about targeting individuals, targeting populations, and targeting behaviors. But I think that what actually might fuel health behavior is this shift in frame. Because in the first example, next slide, please, community members are targets of our program or our intervention. And in this second, community members are agents. And to me, this small shift in language creates an agentic mindset that is potentially critical to any racial justice or health equity lens. And so one question that I might encourage folks to consider about language as you consider both at the federal and also the jurisdictional level to develop and refine innovative DIS strategies and programs is, next slide, to what extent can the language used in DIS training, the very language itself, reflect a mission to identify and intervene upon factors that motivate, support, and inspire health behavior? And I know that that is already your mission, absolutely. But being as intentional as possible about language that's used with and about clients, I think can be a critical component of realizing that mission. So then the other part, stop, go back, please. I'll tell you, thanks. I'm like obsessive about that. So the other part of this analogy that's so critical is that providing fuel has to go hand in hand with reducing friction. And here's where the connection between my work as a psychologist and my work as an implementation scientist, I think, come together. How do we actually organize systems that reduce friction? And I know that the focus of this webinar is recruitment, retention, and training, and it isn't necessarily about program design. But I also know that so many of you in this webinar right now are intimately and actively involved with program implementation. And so I'd just like to take an opportunity to make this connection between recruitment, retention, and training activities for the workforce and actual program design and implementation. And in this vein, I think that this most important lesson is also in mindset or framing. And I know that many of you know this already, and also it's not rocket science, but I think that it's worth saying. Now you can go to the next slide if you don't mind. That in order to build trust, we have to act. And this means many things, but I think that there are three lessons that actually have come to us in the last several years from recent work and experience with COVID, and specifically COVID vaccine rollout, that are critical to be internalized for the potential of reinvigorating DIS work. The first is that client attitudes towards interventions, whether they be surveillance interviews, testing, treatment, care engagement, vaccines, are reciprocally impacted by their perceived and actual access to these interventions. Next slide. I'm sure many of you are familiar with the work of Dr. Rhea Boyd, who wrote early on in vaccine distribution efforts about the role of access rather than attitudes in determining vaccine uptake. And although I know that there are constraints on DIS programs and activities, I wonder about the extent to which DIS programs can consider specific components that we know increase accessibility of programs and services. Can you slip two slides and go to the one with the rocket? Just skip through the quote. Yeah, thanks. So we know that we can increase the accessibility of programs and services by making them streamlined and one-stop, emphasizing universality and normalization rather than risk or exceptionalism. And this is particularly true in the context of sexual health. Being flexible in terms of hours, location, and intensity. And this is something that DIS, I think, does all the time. And focusing on care that is values-based and values reflective. And so while many of this is already components of DIS implementation, I'd be interested in whether there are specific aspects of DIS that you all think could be enhanced to increase these components. Which brings me to the second sort of aspect of building trust and acting trustworthy. Next slide. Which is designing user-focused systems with equity as the primary goal rather than the secondary problem to be solved. And here's what I mean by this. I feel like too often we start with a provider-focused goal or a health systems-focused goal, like how do we create this system? How do we create a vaccine delivery system? How do we connect DIS across HIV or STD or COVID? And then we say, okay, given this delivery system that we've created, how do we reduce disparities in that existing system? How do we make sure that within the constraints of this system, Black and brown patients or poor patients or sexual and gender minority patients actually come or actually access our system? And in contrast, I think that turning this paradigm on its head is the whole point. That a racial justice or a health equity lens doesn't say, how can we reduce disparities in our existing system? Next slide, please. It says instead, how can I rework or refine or amend my system? It doesn't talk about that aspect. It says what system would actually ensure, not increase, but ensure racial equity or health equity. And that's the system that I want to build in the first place. And I am not saying that that is easy, but I think, and again, like this is in response to several comments that I saw in the chat, like I think we do know the answer. I think that we do know in a lot of situations, strategies that will work for people, but we need to make sure that racial equity or health equity is the goal and not the corollary. And so my sort of question, or maybe my challenge in this talk, is whether or not there's an opportunity right now in thinking about modifications to DIS recruitment, retention, training, certification, to also think about the construction of the system itself. And this relates to this third piece, which Glenn mentioned as well, which I think is so critical in this process of acting trustworthy, which is, next slide, please, demonstrating that we care about the whole person that we're trying to reach. Because it's not lost on the people and communities that we work with that you want me to get this vaccine, or you want me to get tested for STDs, or you want me to talk to you about partner and contact tracing. But you're not willing, I don't mean you personally, but our system is not willing to give me full access to healthcare as a human right for my other medical conditions or concerns. And, you know, in my experience, at least working in New York City, the folks that we're contacting because of STDs or because of HIV or because of TB are the same folks who are living with other medical concerns, the same folks who haven't had access to regular medical care for asthma or diabetes or hypertension. And I raise this because I'm wondering whether in this moment, we might have the potential to be more comprehensive, as Glenn mentioned, in training, in program development, to potentially break down or build across traditional silos, traditional categorical funding streams to develop a more holistic approach to public health intervention. So one question that this health equity intervention approach would have for DIS training is, next slide, does the current moment provide an opportunity to break down silos and integrate disease intervention services across disease and prevention goals? Or put another way, to what extent does the experience with COVID support conceptualization and presentation of DIS as health equity interventionists, trained to engage with people about barriers to healthcare on a broader scale? And to what extent might that help with feelings of purpose and impact and meaning in the ways in which DIS experience their work? Because in the words of Audre Lorde, next slide, There is no such thing as a single issue struggle because we do not live single issue lives. And I think this is one of our best lessons from COVID, even though we didn't really need to learn it. But I think now perhaps we need to use it. And so the question for training becomes, if we're going to try and use a reimagining of DIS training to potentially reshape DIS programs, next slide, how can DIS training be as creative, innovative, and unrelenting as possible? And to be brutally honest, my main audience for this particular comment is CDC itself. The idea of user-focused, equity-focused, holistic, silo-busting program innovation needs to be initiated and supported at the federal level. And I was so excited to see Don Broussard's study, as it was described by Michael Castro, this framing a future vision of partner services. So many of these ideas are exactly, I think, the type of leadership that's most needed. So I just invoked Audre Lorde, and for my sort of last set of points, I'm going to invoke somebody who is not usually paired with her. Next slide. And that's Winston Churchill, who said, "I'm always ready to learn, although I do not always like being taught." And I want to use this quote because the last point that I'd like to make about DIS training is that, next slide, it needs to be creative, innovative, and engaging. It needs to be relevant and responsive to the people that it is designed to train. And again, I do not need to explain this to folks on this call. But as you are thinking about the content of competencies for the DIS workforce, I think it is equally important to think about how the process of training, the experience that I have when training, and like, boy, our webinar is lousy, but that's a whole other talk. But the actual experience of the process of training, right, can positively or negatively impact the people who are being trained. And I'll just articulate 5 aspects of fuel and friction that relate specifically to the DIS workforce themselves that I think might be useful to consider in some of your conversations. Next slide. I think that training programs can provide either fuel or friction for staff. And what I think provides fuel is focusing on skills, expertise, mission, and purpose that help staff find and make their jobs meaningful and rewarding. And we've talked a lot over the course of this session about burnout. And I think that case conferencing actually, in my experience, is critical for this. And also specific emotion regulation strategies. There are strategies that can be taught to individuals who need to engage in a tremendous amount of emotional labor that can overcome and guard against this idea of compassion fatigue. And I think that this is directly related to a lot of the conversations that you've been having about conceptualizing training as levels of professional development, certification, recertification, differential certification to enable those ladders. You've talked about this a lot as well, focus on sort of an ongoing training for supervisors, reducing burnout for supervisors as well, and promoting facilitating case conferencing types of conversations, I think can also promote retention and reduce burnout. Emphasizing continuous professional development improvement, which has been spoken about a lot, I think, already today. And then lastly, sort of ensuring that the training requirements at the federal level support rather than burden local sites. And I think that that is something certainly that Glenn mentioned as well. So in this vein, the overarching question is, next slide. To what extent can DIS training support success by actually promoting a larger DIS system that is designed to be as successful as possible? So in summary, next slide, these were my sort of perspectives and considerations as all of you are thinking about this work, focusing on language that provides fuel, designing programs that reduce friction, considering health equity as a primary goal rather than a secondary problem, prioritizing DIS programs that can operate across people's multi-issue lives, to build a trust act trustworthy, and transform training to transform reality. Thank you for listening. I will now turn it over to Dr. Leandra Mann.
Thank you, Sari. So good afternoon, everyone. I'm Leandro Mena, the Director of the CDC's Division of STD Prevention. Thank you to Sergey Aral and the meeting organizers for the opportunity to speak with you today. Also, many thanks to Amber Herald, who assisted me developing this presentation, as well as those in our division that provide their feedback. We have heard incredible presentations today for the past few hours that highlighted, some of the key issues surrounding the DIS workforce, recruitment, retention, and training. We have looked at retention and cost effectiveness. We have furthered the discussion on barriers for recruiting DIS in the workforce at various levels. And we have seen where we are with training, opportunities for disease intervention specialists. Just minutes ago, Dr. Gottlieb really talked to us about how can DIS training be as creative, innovative, and unrelenting as possible. So during my presentation today, I think this is a perfect segue. I really hope to challenge us, to continue thinking out of the box and beyond in what are the next steps in expanding and shaping our country's DIS workforce. What do we want, to see in our DIS workforce? I mean, where do we need to be and how do we get there? How we look, at the past, as a reference, but imagine and invest in expanding a DIS workforce that is responsive to our current realities and the future needs of our nation. Next slide, please. So let's start, and let's take a step back. So how do we get where we are? What effect, has the way our approach to STDs control and prevention shaped today's disease intervention specialist work? Next slide. STD control in the United States overall has been fairly consistent for decades. We have focused on the health education, promotion, and behavior change with a directive to identify and treat individuals and locate any contacts. A seemingly simple multi-step process. We know the reality of these steps in practice is far from more challenging. And we see this playing out not only with STDs, but other infectious diseases. All we have to do is look at COVID for a most recent example. This control developed in a framework with individual-based interventions housed under a public sector responsibility, the STD clinic, and the expert role position to meet the core tenets of identification and treatment was and still is the disease intervention specialist. We saw tremendous growth in the field in the 1980s through the 1990s. We had large numbers of boots on the ground, finding syphilis cases, getting people treated, building community rapport, and establishing trust with public health. We saw the numbers of syphilis. The primary case DIS investigate received, and as cases receded, our investment in public health and interventions to control STDs did as well. Unfortunately, we have seen STD cases skyrocket in recent years. Why? We have these approaches of identifying and treating individuals in places that even include screening those who are asymptomatic. We know these approaches can be effective. So what are we still missing in our approach, or what can we do? Where can it be improved, to more effectively control and prevent STDs? Next slide, please. So social determinants of health, are key contributors to the increases of STDs. For years, the epidemiologic risk factors for STDs were seen as individual factors, such as having multiple partners, history of STDs, substance use, or transactional sex for money or drugs, along with socioeconomic factors. But the drivers and determinants of persistent disparities in STDs are far more intricate. Stigma, discrimination, racism, sexual and gender phobias, poverty, transportation challenges, safe housing, access to healthcare and education. These social determinants of health, along with others, play a significant role in not only STDs, but HIV, viral hepatitis, and substance misuse. To effectively address STDs, requires coordinated, integrated efforts that address these endemics. This in turn affects the skill set and areas of expertise our workforce will need to develop or leverage, from partners. So let's take a look of those DIS skills and see how they correspond. Next slide, please. Here we see a recap of DIS skills. Some of them, all of them we have mentioned during the different talks today. DIS, possess unique skills designed to disease intervention and investigation, with skills in problem solving, negotiation, and communication. DIS specializes in public health investigation, case management and analysis, the provider of community engagement, outbreak detection and response, and many more. Next, these skills are essential to engaging with social determinants of health. So how do we cultivate skills and ensure DIS reaching their full potential? We live, work, and play in communities that inform our interactions around us, help conduct our ideas, our beliefs, our values, our manner of speech. How can we translate lived experience that informs one's DIS skill set to another? How do we develop cultural competency skills if interacting with a community we're not familiar with? How does this impact rapport? How does this affect trust? So these are areas that DIS has traversed. This is the context in which the future and competitive DIS workforce is being shaped. Next slide, please. However, there are challenges that we must anticipate as we look to the future of disease intervention specialists. And the first step is identifying those challenges, which we have seen today surrounding retention, recruitment, and training. Next slide. There are several challenges that have been identified when talking to our jurisdictions and disease intervention specialists. A large obstacle to retention is a limited or lack of a clear career pathway for many DIS. If a DIS enters a local health department, trains, and receives their certification, what opportunities does the DIS have to move up in the career ladder? Is the only option for career a senior DIS position to supervise a role to the manager of the program? Do other options exist? And if a ladder exists, how easily can they move up the ladder? What does a competitive salary look like as the DIS progresses through their career? Next slide. With recruitment, several hiring limitations can exist. What degree requirements does the entry DIS require? Some entry-level positions require master's degrees, while some require 2 to 4 years university degrees, while others may be willing to hire a person with a high school degree and train them. However, this affects where we seek candidates for DIS, their expectation for a career pathway, for competitive pay, and the likelihood that they will remain in the position past a couple of years. And while a degree qualification can be self-limiting in a hiring pool, it also has the potential to elevate how DIS career pathways is viewed in certain circles. The years of experience of a DIS position is required to have is another limitation. It can create the same obstacle as we see with a degree requirement. For instance, a position may require a degree, or in lieu of a degree require a minimum of 4 years experience in STD, HIV, health, or the public health field, or another closely related field. Then we have a local policies for hiring. A state may dictate that the employees in the position have a degree requirement. There may be hiring freezes occurring. Then there's a space allocation and the need for technology as a DIS hire requires. We also have salary to consider. DIS positions tend to be lower salary positions. How do items such as travel and managed reimbursement for visiting clients factors into considerations on what salary a DIS is paid, if at all? And how do we get DIS salaries to be competitive? What options do we have for funding those positions at higher amount? Next slide. There are several challenges that have been identified when talking to our jurisdictions and DIS. And a large obstacle to rotation is limited or lack of a clear career pathway for many DIS. If a DIS enters a local health department, next slide, please. So we have also the technology limitations. DIS rarely, or in case rely on case management systems, and some systems excel in areas where others do not. So the efficiency of those systems directly affects workload. So how easily can the systems be tailored to a jurisdiction? How easy is to train someone and get them to access to the system? I mean, we saw the example of Chicago and Howard Brown, which again, congratulations. I mean, I think, and recognition to Chicago Department of Health that was able to overcome some of the challenges that I know many jurisdictions, are not really and cannot really easily overcome to allow external employees access, to their case management systems. So how well do systems work between jurisdictions? It's another problem. Within the state, if counties use different systems. Then there is the other layer of electronic health records for receiving critical information. DIS need to conduct their case investigations. How well do EHR systems integrate with the case management systems, if at all? And finally, there is the need to adapt functions of partner notification in the context of the digital world where many people meet their partners. Next slide. So we also have to consider the behavioral and network challenges of people over the past year. Trust, confidentiality, and privacy concerns are prevalent today, particularly when dealing with a health topic. The rapport DIS build is crucial for partner elicitation. Is establishing this rapport easier in person versus over the phone? How has texting and caller ID or an individual preference to communicate only by text versus talking on the phone possibly reduce the number of partners elicited by DIS? When it comes to meeting people, geographic changes whether distance, geography changes where distance travels, or meeting locations have expanded from prior decades. In one day, a person can easily drive 50 plus miles and meet several people in various cities. This list is by no means exhaustive, but highlights various barriers that exist in establishing a most effective and skilled DIS workforce. We must continue to identify challenges faced by DIS. Next slide. Once those challenges are identified, how do we adapt? What is needed? And our actions quickly quickly enough to a rapidly changing world. Our work does not exist in a vacuum if we are to truly elicit change in STD increases. The skills and training required for the workforce have to meet the needs of the people we interact within our evolving environments. Next slide. While we have discussed several challenges related to today's topic of retention, recruitment, and training, there are additional questions we still need to explore when we look towards the future DIS. While we look at the past for reference, how do we envision the modern DIS workforce to be? Next slide. How do we make DIS work more effective at the local level, at the national level, considering some of the issues I just mentioned? How does this version of DIS work fit with our 21st century life? How does a reimagination of the future DIS coincide with work around the social determinants of health? What overlapping areas may exist? How do we ensure only limited and not duplicative efforts? What is our return on investment in terms of the value DIS receive for the training in place? How many DIS are needed, to turn the tide? Is this number achievable based on what is needed for training or cost, etc.? How could this number be achievable if we don't necessarily perceive it to be? Are there alternatives, to the type of work DIS historically have done to take into consideration changing technology to reduce the DIS number needed to turn the tide while remaining or increasing, increasing effectiveness? The pandemic has shown us that we need to have an on-the-ground scalable DIS workforce, while at the same time recognizing that addressing COVID right now is beyond the case investigation, contact tracing, and that integrated teams are important. We have in our hands an opportunity for STDs with the DIS workforce supplement. This increase in DIS workforce has potential to reverse the STD increases and be prepared for any future outbreaks. And honestly, this may be our best chance to demonstrate a return on investment that will help to maintain this kind of investment in our programs for years to come. What are those activities that will allow us to maintain the DIS workforce through and be skillfully trained? Are there models of similar career fields that we can turn to for inspiration when looking at future DIS? What does the retention, recruitment, and training look like in this career or models? Some options that we may be able to consider are the community health worker model for chronic disease. The combined teams, many cities are developing to conduct outreach for people experiencing homelessness. These teams may include a public health nurse, a mental health clinician, an outreach worker, and a disease intervention specialist. The nursing rotation model presented today by Tom earlier today may be an example, or even a clinical or population researcher career path that may be able to support, research efforts, retention, recruitment and retention. So what field can we already take advantage of? The community health worker, perhaps, do they have, training qualities? Some of the things that Dr. Gallup mentioned in her talk made me think about, some of the affinity and the way community health workers are trained, right, to motivate and to engage people, as potential opportunities, that we can use, in our training or DIS. So we have to think what makes a truly exceptional DIS. What are the attributes, of that truly exceptional DIS that we have and we recognize? And how can we replicate, and scale up, those characteristics? Next slide. We have asked a myriad of questions today in trying to understand where we need to be with our DIS workforce. But how do we get there? What initial steps can we take with so many questions still on the table? Next slide. So there are 3 key areas that we may consider starting with. 1, work to strengthen the DIS conversation happening at all levels of engagement about who DIS are, what they do, and what is needed to ensure their success. This includes the identification of solutions, if proposed, to those challenges we outline. And if it's not just strengthening the conversation with our usual STD partners, we can explore new partnerships. And we should explore new partnerships, for collaboration and integration to leverage support around DIS. In the conversation, we must highlight the key components that make DIS the experts in disease investigation and distinguish them from other positions that are similar. These are the key components of our recruitment and training should focus on developing. The DIS are embedded in the community. The DIS possess cultural competency. The DIS have emotional intelligence. The DIS use motivational interviewing skills. Next slide, or next click. 2, we want to work to establish a career pathway for DIS that provides professional growth and competitive compensation. DIS is one of the entry points into the field of public health. Possible career pathways may start with something similar to the Public Health Associate Program and then evolve to, for example, a clinical path where DIS will be integrated into clinical teams. Chicago Department of Health has really given us an excellent, example, right, with their relationship with Howard Brown. Perhaps a surveillance pathway where DIS will be integrated into surveillance teams, a program management pathway, in public health, or possibly a technical assistance and training pathway. But once the pathways are identified, developing of training and mentorship is necessary to meet each pathway and make sure that the DIS are successful with it. So additionally, depending on the pathway selected, development of a concentration in certain public health degrees up to a certification could be considered. This could affect how current training and DIS requirements create certain views and biases colleagues in other fields and individuals outside the public health disease view DIS. Next slide. And 3, we need to work to fill in the data gaps surrounding the DIS workforce and DIS activities. There is a great need to collect data that will help us to build DIS models that will inform next steps and needs of DIS and how we will be able to best maintain this important component of our public health workforce. There are many questions still to answer when we look to our future DIS. And I hope that our conversation today helps us begin seeking answers to those questions while uncovering others that we have yet to ask. Ensuring an adequate DIS workforce that is scalable, adaptable, and has access to training needs will be a challenge. We have a journey ahead ahead of us to understanding and enacting what our future DIS workforce will be. I am really excited to work together in this path with you, hopefully for the many months and many years to come. Next slide. Thank you. Now, our moderator, Raul Romaguera, is coming next.
Good afternoon, everyone. My name is Raul Romaguera, and I am the Deputy Director of the Division of STD Prevention. Thank you, Dr. Golub, Dr. Mena, and Mr. Christie for excellent presentations. I would like to invite everyone to submit your questions. We only have a couple of questions here on the panel, but I'm going to start with my own questions. And this one is for Glenn. Glenn, what will the launch process for the new DIS Foundational course look like?
Thanks, Dr. Omagura. Good question. So what we're planning to do, the launch of the new training is going to be announced on the Training Center website, the DITC website. We're also going to launch it on the DIS webpage, the STD DIS webpage that I mentioned during my presentation. And we're going to collaborate with our project officer colleagues here in the division, as well as NCSD, to help us get the word out through their established communication channels as well.
Thank you. We also heard through many of the presentations today that one of the challenges in retaining DIS is the lack of a career path for DIS. So this is a question for all of you. How can training and DIS certification support DIS retention and provide a career path for DIS? And Glenn, maybe you can talk whether the DIS training that CDC is currently supporting actually provide training opportunities for a career path or for growth in the DIS job, and how the DIS supervisory training will support that.
Thanks. I want to begin by giving an update to DIS certification came up quite a bit during conversations today. And I wanted folks to know that where we are right now, so we did this feasibility assessment a few years ago. And the biggest hurdle we've had since then was identifying the funding source to get going with certification. And I do want to share that the American Rescue Plan Act did afford us the opportunity now to identify the funding for certification. And this year, we hope to identify a accredited certification body to award funds to begin development of the certification. And we anticipate that this will be a 4-year process to get this developed and implemented. Now, how does it help with career pathways? You know, we learned through the feasibility and assessment project that the standardization of the training and standardizing the performance expectation, along with certification, establishing credibility, within the field, will enable programs to better define their different levels of DIS, so to speak, based on, what those performance expectations may be. I know currently, I've learned since coming over into STD that there are programs out there that already have identified at their level different levels of DIS. And we hope that the certification will help build a little bit more consistency across the country and how that's being done. And more importantly, I think certification will allow programs to use this established demonstration of proficiency as a mean to also address the salary and compensation issues that have been talked about here before, to make it easier for them to create these positions and to fund them or pay people more as they rise through these different levels. And I think there was another part of it, Raul, beyond certification.
Yes, it was about how training and certification can provide a career path, and whether the training that CDC is currently developing is going to provide these opportunities or this career path that DIS are interested in.
Yeah, with regards to the training and supervisor, we hope that, and this is something we've been hearing for a while, that there is this need for a well-structured supervisor training program. Many programs are relying on their own in-house expertise, the passing on of knowledge from from peers or colleagues to do this. And there are different programs developed to train supervisors. We're hoping that creating this national program will again offer that standardization in training, and will establish the level of expectations that can be out there for supervisors to again bolster the point made about what folks will need to demonstrate or complete in either training and performance to be able to qualify for these positions, to make it easier for programs to define what and who a supervisor is or should know how to do.
If I can add to that, Raul, I also say, that a lot of this, happens at the local level, right? You get a new DIS, and you make training, and for the first 2 years, right? In many ways, we have many examples, right? You have, professionals, in law school and medicine, that you go through a residency program, and you do 1 or 2 years, where you get the core basic expertise. Then you can, even in business, you can rotate, give the opportunity to someone who has gone through that initial process to rotate through different functions, public health in the same public health department, right? To expose them to different ways and allow them that kind of a specialization that will really create that kind of career pathway for that individual. For some people, could be, to continue as managers of decision division specialists, and supervisor. Some other, maybe more training technical assistance that is always going to be needed. For some other, maybe, as I say, when I talk, as a prevention, and some of the things that we do are being medicalized, right? Really being, integration of some DIS into clinical teams that work more effectively between diagnosis, treatment, referral, and treatment of partners. Some other may move into more the surveillance area. So again, I think that a lot of this, has, it's actually locally, and one kind of opportunities and can be created at a local level to assure this career pathway that will help in the retention. Because again, a big investment is made into, recruitment and training of DIS.
Thank you. Dr. Golub, the next one is for you. At the end of your presentation, you actually had a question for CDC, and I would like to throw that question back to you. You actually asked, how can centralized training or these certification requirements best support rather than burden local sites? I would like to hear from you how you suggest a CDC approach decentralized training and coordinate with the local sites. And then I'll ask CDC how they plan to do it.
Sure. I think, and this actually, I have to give credit where credit is due. I mean, this was definitely something that came out of my conversation with Glenn, who's already, I know, thinking about this question and this process for for training at the federal level. I think that, one of the things that I understand is the extent to which local jurisdictions have elements of training programs that they have developed in-house. And I think that one question is there already expertise and training that's been developed at the local level that could, bubble up to the federal level and be more useful to other jurisdictions? Is there a way of sort of harnessing or enabling increased conversation about some of those more locally developed trainings? But the other piece that I think is sort of already happening is this question of making sure that the ways in which the training requirements, especially around certification, are designed are consistent with the needs that local offices have told you that they have.
Thank you. And then Glenn, can you talk a little bit about how you think CDC is planning to harness all of this local training that is currently being developed?
Yeah, thanks, Rob. And that's a really good question. We are fortunate in the fact that here at CDC, and specifically in our branch, we have folks that are embedded in state programs and local programs. So they have inherent knowledge of, what DIS do in the field, what are the training that's needed to support them. And many of our staff, even here, are former DIS in the field. But I think the process that we have in place, so we have some structural process in place. We have a formal training needs assessment process that allows programs to provide feedback on their training needs through our training centers. So our training centers are involved in that exercise of doing these training needs. Our colleagues within the program branch, the project officers, they work with the programs and they look at these reports that come in that describe what it is that programs think they may need training on, what's working well, what's not. And those things feed into what we use in working with the training centers to identify the kind of training that's needed. I think also important, it was mentioned earlier about the job task analysis, talking about certification and the core competencies in the job task analysis that were identified. That's important for us to use those to develop the training, again, because it ensures that the training being developed is the best, most comprehensive type of training that the DIS workforce need. And it goes to a point that Dr. Gallup mentioned earlier about rather the burden on these programs. And I think having this process where we get these input, whether there be through the training and needs assessment or through other forums that we may use, these approaches will help us to make sure that right now programs aren't out there trying to duplicate effort in developing training for their staff. We know they need to develop training that augments the national training and focuses on their local needs, but they don't spend the time and the resources that they have trying to develop training that we can develop, that they can build on. They need to be focused on training that is more geared towards the local needs that they have, the specific types of requirement that we may not necessarily be able to capture in national training programs. I hope that answered the question.
Yes, and can you stay? I have a follow-up question to this, and I think it's the challenge that local health departments currently have. They're hiring a lot of DIS with no workforce funding. And of course, the training is not available yet. So how are they supposed to be training all of the newly hired DIS that are coming on board while they wait for a DIS training program?
Yeah, thank you for that question. We've heard this question quite a bit, and I do appreciate the challenge and the frustration that I hear through some of these questions. We are working as fast as we can to get this new fundamental course out and available. And as you said, we anticipate that it's going to be available in the spring of this year. I think in the interim, as I mentioned in my presentation, is we have worked with colleagues to put together a DIS training plan that we have hosted on CDC Train. It's the online training that programs can use right now. It covered, like I mentioned, general public health topics. It covers topics around, contact investigation, and rather, the other core competency type training that DIS need to have. It also goes into some disease specific training. It covers courses or training around outbreak response and so forth. And also, and I do know that that's online, and what a lot of programs really need right now is that skill-based training to really teach their new DIS or inexperienced DIS those interviewing skills that they need. And we're hoping that with the interviewing training that's out there, the skill-based training around COVID, though it may not be, have the sexual health component, that it can still be of value to them in the interim to develop the interviewing skills of their workforce because it does teach them about, the communication skill, applying those cultural humility, cultural competency skills in interviewing that could be applicable to the work that they're doing. And with the other resources that we have online, we're hoping that that is helpful in reducing some of the burden they have right now in trying to do the training themselves while they're waiting for the new DIS course.
Thank you. And Leandro, this one is for you. You mentioned leveraging community health workers several times. What aspect of the community health worker resonates with you that we may not see in our current DIS?
I think, again, the idea and the thought of community health workers, comes from how they operate, right? Community health workers in many ways are a bridge, between communities and the healthcare system. And I envision sometimes, because of what we recognize, the impact, right, of the social determinants of health, right, in driving, the prevalence of many of the diseases, that we care for, and how, disease intervention specialists really can become more aware, and can be really trained. Dr. Gallup mentioned about, the communication, right? In a communication approach that really is more empowering and motivating, and I think that's really, probably intrinsical to the community health worker model of training that may not be necessary, part of a traditional, DIS training. I know, and I can't remember the jurisdiction. There's a jurisdiction now that is actually hiring community health workers and training them as disease intervention specialists, right? So I think that has a tremendous potential to really show us a new, way forward. I do think, again, that there may be some gain, right, in getting our current DIS force and identifying those, I think, attributes of DIS, of our community health workers that are very aware of resources in the community, that are very, that approach, right, the individuals, in a more, I think, in a different way, right, more, kind of a motivating, enabling, supporting kind of way that perhaps, may, improve, the overall efficiency, right, of the DIS doing, what they do, what they're supposed to do in terms of case investigation, contact tracing, but really, linking, individuals to our public health systems.
Thank you. And we have limited time now, but I would like to ask this question to Glenn before we end the session. Can you identify any other training other than COVID-19 leadership training for new DIS supervisors?
Thanks for the question, Raul. Unfortunately, I can't at this time, but I did make note of that question, and it's something for me to do a further investigation. I'm not aware of any other supervisor training per se that could be directed towards this work group other than the leadership one that's being provided right now by the COVID training program.
Okay, and then I want to cover this last one about DIS certification. Have CDC considered collaborating with the health educators or public health certification organizations to assist with developing the DIS accreditation program?
Good question. When we develop the statement of work for whoever is going to be awarded the funds to develop the certification program, that will be one of the expectation of whoever that accredited body is that they collaborate with other established accreditation certification bodies to use the information that we've learned from the DIS certification project to develop the DIS certification. So we anticipate that kind of collaboration will occur as part of the process of developing the certification.
Okay, thank you. Thank you, Dr. Golub. Thank you, Dr. Mena and Mr. Christie. And next slide. And now, just to wrap up the meeting, we want to discuss where do we go from here. And I would like to introduce Dr. Phoebe Thorpe.
Thank you so much for joining us, everyone. And I would like to take a moment to thank all of the excellent speakers we had today who shared their insights, and also to the facilitators who helped us with the Q&A sessions. Always important to hear what the audience is thinking and their questions. I think we heard many great ideas about DIS retention, recruitment, and training today. And I believe we hope they will help spark discussions about the future of DIS. I'm Dr. Phoebe Thorpe, and I currently serve as the branch chief for PDEB in DSDDP. And some of you may know that I worked as a DIS, and I treasure that experience. I learned so many valuable lessons that I have carried forward and have served me well in my career in many different aspects. In the last few minutes of today's session, I would like to briefly share my thoughts about the lessons from COVID and a few next steps in the evolution of the DIS workforce and DIS work. Next slide, please. Throughout COVID, DIS have been called to action, and there have been a myriad of experiences, both ups and downs, from the challenges COVID presented. In some ways, COVID was an opportunity to remind us of what DIS do well and their skills. And I would say that DIS enjoy helping and working with people, whether they're clients, partners, providers, community members, stakeholders, anyone and everyone, to create a healthier possibility. Next slide. DIS are flexible, they're resilient, they like to get things done, and they like to get things done right. So how can we take next slide? So how can we take all of those skills and build a better future? Recently, the DIS workforce has had a large bolus of funding. And today, we are asking ourselves how we can build a better future for DIS and the STD program. And there are a few things that COVID taught us that I'd like to highlight. First, people are our most valuable asset, and anything we do, we should build on the existing strengths of DIS. And the other two items are about getting things done more efficiently to save DIS time and effort, kind of like the quality that Sarit had mentioned earlier. Number two, we need data systems that work for us instead of data systems that create more work for us. Interoperability between data sources and systemic reviews need to be baked into our data systems. And then third, with COVID, the way healthcare is provided and new technology have changed how we are approaching screening, testing, and exposure notification. This is a chance to see how we can adapt these changes to move our field forward. And I will expand a little bit on each of these in the next slides. One of the biggest DIS strengths is the ability to connect with people at a variety of levels. To do this, DIS use soft skills. Soft skills are used to listen and relate with people and to motivate individuals to seek care and reduce risk. But soft skills can't be learned from a book. Mentoring and learning through on-the-job training, shadowing, and talking with other DIS is how soft skills are developed and refined. As we heard today from Dawn, mentoring reduces fatigue, burnout, and can help show new DIS how to cope with the various stresses of the work of DIS, including hopefully demonstrating the importance of self-care. And lastly, we as a nation were lucky that the DIS are so flexible and we're able to pivot to help with COVID. And we expect that DIS will continue to be asked to respond to outbreaks in their communities. Cross-training DIS for other diseases, especially HIV, hepatitis, and TB, will help DIS be prepared to help their community and furthers their flexibility in the future. Cross-training also arms DIS with knowledge in advance, preparing them to be a reliable source of information, which is shown to be critical with COVID. Next slide. DIS realized the importance of connecting with their communities and listening to the barriers and successes within the community. We should continue to engage our community to define priorities and identify potential solutions. And this isn't just about engaging with community members. There are also other groups working on the communities, and COVID has reminded us that the difficulties we face and their solutions are larger than just what we can do ourselves. Even with the influx of funding, we cannot afford to work in silos. This is an opportunity to build partnerships with providers, not just healthcare providers, but other providers in the communities. It's important to know about the resources in the community to help the individuals that we serve, and not just to treat and prevent STDs, but to help the whole person, just as Sarit had mentioned today. We, the field of STD, cannot realistically, for instance, prevent congenital syphilis if drug use is an underlying cause. But working with groups and individuals that provide substance use services can help both of us reach our goals. And lastly, our diseases are sexually transmitted, and we need to focus on increasing sexual health in our communities. After all, as we all know, sexuality is part of being human. Next slide. And while community engagement can help us find what needs improvement, data helps us know where are gaps and what are true changes. Key to understanding what is happening and where it's happening is routinely reviewing the data. And while some call this bean counting, and I say this knowing that I relish this aspect of data analysis, computers can do this better than people can. And establishing a software program that routinely and systematically reviews the data and lets people then go in and check and see what's going on, can identify the difference between a simple upward trend and a new outbreak. And if an outbreak is detected, like what's happening with syphilis in many parts of the US, DIS can work with the community and stakeholders to respond collectively. It's like an opportunity to practice the DIS skills that we've been talking about today. Next slide. Data systems can also harness to collate a wide variety of information that comes into health departments, and interoperability is key here. COVID has really shown the importance of data systems that can talk to one another. This reduces the administrative burden to getting data from pieces of data into case reports, and also reduces the lag time between when the various pieces of information are received and when DIS actually can start acting on it. Another important COVID lesson is remote reviewing of information from other sources, such as hospitals or large institutions. It's much more efficient to log in from your desktop than to spend the time to drive to each different hospital or provider's office, wait to see a medical record, review it, and then drive back. And as Dr. Mina mentioned, this might be another way to save time and effort. It may need a little bit more work, but I think it would be worth it. Next slide. We also need to build on recent advances to move the field forward. Say this a little bit tongue in cheek, but thanks to COVID, new screening paradigms are being employed and patients' expectations have changed. We should take advantage of this to shift and expand where STD screening can be done. Not only expanding the use of express visits, which have proved to be very popular with some communities, but we should also look for other ways, other non-traditional settings such as pharmacies and grocery stores, where self-collection and screening can be offered within current regulatory requirements. And then as more tests are approved for use in non-clinical settings, screenings may be expanded even further. Next slide. And lastly, COVID has showed us that there's lots of ways to notify people of their exposure. In fact, several exposure notification apps were developed for COVID exposure notification and follow-up monitoring. And if people are using apps to help find their sex partners, is there a way to adapt those apps to notify their partners, kind of like a self-notification initiated by the infected person? We would probably need to have a little bit of code so that when the person comes in for treatment, we can connect it and we ensure that the partner gets all the care that they need. But I mean, that really makes me think about all of the anonymous partners that might be notified in that way. And it could be a big improvement in getting people who don't know that they're exposed in for treatment. Next slide. If there's one thing COVID has required of us, it's to think about how to get more done with less. And maybe I'm oversimplifying here, but this is where I would focus. What can we build and put in place to make the work of DIS more effective, to have more impact and with less effort. And thank you for joining us today. I've appreciated hearing, and to the speakers and the audience, I've appreciated hearing your thoughts and your questions. And you can look for a recording of this session on the STD website in a few months. Thank you.